As you settle into this moment, wherever you find yourself, notice the gentle rhythm of your breathing. Notice the weight of your body against whatever surface supports you. In this very instant, deep within you, a remarkable system continues its quiet, ceaseless work. Your kidneys, paired organs nestled against the back wall of your abdomen, are filtering your blood, balancing your chemistry, maintaining the precise conditions that allow every cell in your body to thrive. They work without fanfare, without conscious direction, performing hundreds of intricate tasks each moment with extraordinary precision. Tonight, we explore the renal system, the master chemist and quality controller of your internal environment. This is a journey through one of the body's most elegant achievements, a system that manages water and salt, removes waste and toxins, regulates blood pressure, produces hormones, and maintains the delicate chemical balance upon which life depends. We will move through this landscape gently, not rushing toward facts to memorize, but allowing understanding to unfold naturally the way water finds its path through stone. The renal system represents something remarkable in human physiology. Within 2 fist-sized organs, your body has created a filtering apparatus so sophisticated that it processes your entire blood volume approximately 60 times each day. It maintains the concentration of hundreds of different substances within astonishingly narrow ranges. It responds to thousands of signals simultaneously, adjusting its function moment by moment to meet your body's changing needs. And it accomplishes all of this with the efficiency and reliability that engineers spend careers trying to replicate in machines. You need not remember every detail as we journey together. Instead, allow yourself to appreciate the architecture, the harmony, the sheer ingenuity of these systems working within you right now. Even as you rest here, your kidneys are making millions of tiny adjustments, reading the chemical signatures in your blood, deciding what to keep and what to release, maintaining you in a state of exquisite balance. Let us begin gently with the basic landscape of the renal system itself. The renal system consists primarily of 2 kidneys, 2 ureters, a bladder, and a urethra. But to say this is rather like describing a city by listing its buildings without mentioning the people, the commerce, the flow of energy and information that makes a city alive. The kidneys themselves are the heart of this system, bean-shaped organs positioned on either side of your spine, just below your rib cage, protected by layers of fat and connective tissue. Each one measures approximately 11 centimeters long, 6 centimeters wide, and 3 centimeters thick. They rest against the posterior abdominal wall, the right kidney sitting slightly lower than the left to accommodate the liver above it. These organs receive an extraordinary amount of blood. 20 to 25% of your cardiac output flows to your kidneys with each heartbeat. This means that of all the blood your heart pumps, 1/4 of it is directed to organs that together weigh less than 1% of your total body weight. This disproportionate blood flow reflects the kidney's primary function. They are quality control centers, constantly sampling and adjusting the composition of your blood. Think of your kidneys as the water treatment facilities of a vast city, your body. Just as a city's water must be constantly filtered, tested, and purified, your blood requires continuous processing to remove waste products, excess substances, and toxins while retaining everything valuable. But unlike a simple filter that merely removes contaminants, your kidneys make intelligent decisions. They assess, they calculate, they respond to hormonal signals and chemical messages, adjusting their function based on your body's immediate needs. The kidneys connect to the rest of the circulatory system through the renal arteries and renal veins. The renal artery brings blood directly from the aorta, your body's main arterial highway, ensuring that the kidneys receive blood at high pressure, fresh from the heart. After processing through the intricate filtration networks within each kidney, blood returns via the renal vein to the inferior vena cava, the great vein that carries blood back to the heart. This circulation creates a loop, a continuous cycle of blood flowing through the kidneys for refinement and adjustment. Once the kidneys have performed their filtering work, the resulting fluid, what we call urine, must travel to a storage reservoir before elimination. This is where the ureters come into play. These are muscular tubes, approximately 25 to 30 centimeters long, that conduct urine from each kidney down to the bladder through a process called peristalsis. These gentle wave-like contractions propel urine downward, working with gravity but not depending entirely upon it. You could, theoretically, urinate while standing on your head, though this is not recommended, because the muscular contractions of the ureters can move urine against gravity. The bladder serves as a reservoir, an expandable storage organ that accumulates urine until you choose to release it. When empty, the bladder resembles a deflated balloon, its muscular walls thick and folded. As urine accumulates, the bladder expands, its walls stretching and thinning to accommodate volumes typically between 300 and 500 milliliters before you feel the urge to void. At capacity, which varies among individuals, but generally reaches around 700 to 800 milliliters, the sensation becomes urgent, though the bladder can hold more in situations where elimination is not immediately possible. Finally, the urethra serves as the exit pathway. This tube conducts urine from the bladder to the external environment. The length and structure of the urethra differ between biological males and females, reflecting the different anatomical configurations, but the function remains constant. Controlled elimination of the waste-laden fluid the kidneys have so carefully prepared. This basic architecture provides the framework, but the true wonder of the renal system lies within the microscopic structure of the kidneys themselves. Each kidney contains approximately 1 million nephrons, and it is within these nephrons that the actual work of filtration and regulation occurs. The nephron represents the functional unit of the kidney, the smallest complete system capable of performing the kidney's essential tasks. Picture a factory production line where raw materials enter at one end and finished products emerge at the other, with multiple stations along the way performing specific transformations. The nephron works similarly, though with far more sophistication than any human-designed assembly line. Each nephron begins with a structure called the glomerulus, a tight ball of capillaries, tiny blood vessels so small that red blood cells must travel through them in single file. This glomerulus sits nestled within a cup-shaped structure called Bowman's capsule, and together, the glomerulus and Bowman's capsule form what we call the renal corpuscle. Here, in this microscopic arena, the first step of urine formation occurs: filtration. Blood entering the glomerulus is under considerable pressure, the same pressure that your heart generates with each contraction. This pressure forces fluid and small dissolved substances out of the blood vessels and into Bowman's capsule. The walls of the glomerular capillaries act as a selective barrier, a sophisticated filter with pores small enough to retain blood cells and large proteins while allowing water, electrolytes, glucose, amino acids, and waste products to pass through. This filtered fluid, now called filtrate, contains both valuable substances the body wishes to retain and waste products destined for elimination. Approximately 180 liters of this filtrate forms each day across all your nephrons combined. To put this in perspective, you have roughly 5 liters of blood in your entire circulatory system, meaning your kidneys filter the equivalent of your entire blood volume 36 times daily. Yet you produce only about 1 to 2 liters of urine each day. The difference between 180 liters filtered and 1 to 2 liters excreted represents one of the kidney's most important functions, reabsorption. From Bowman's capsule, the filtrate flows into the proximal convoluted tubule, the first segment of a long winding pathway through the nephron. The word proximal means near, indicating this tubule's position close to the glomerulus, while convoluted describes its twisted, coiled structure, a design that maximizes surface area within a small space. The cells lining the proximal tubule are specialized for absorption, their surfaces covered with millions of tiny projections called microvilli that increase surface area even further, creating what's known as a brush border. In the proximal tubule, approximately 65% of the filtered water and sodium return to the bloodstream, along with nearly all of the filtered glucose and amino acids. The cells here work actively, using energy to transport substances from the filtrate back into the surrounding capillaries. This is not passive diffusion, but deliberate reclamation, the kidney's way of recovering valuable resources that were filtered out along with waste products. Glucose, for instance, should not appear in urine under normal circumstances. It represents fuel, energy your cells need, and the proximal tubule recovers it completely under normal conditions. Special transporter proteins in the tubule cells bind glucose molecules and shuttle them from the filtrate back into the blood. These transporters have a maximum capacity, however, which becomes important in conditions like diabetes mellitus, where blood glucose levels may exceed the kidney's ability to reabsorb it all, resulting in glucose spilling into the urine, a sign that blood sugar levels have risen beyond normal range. Similarly, amino acids, the building blocks of proteins, are nearly completely reabsorbed in the proximal tubule. The body invests considerable energy in producing proteins and cannot afford to lose their constituent parts in urine. The same applies to bicarbonate, a crucial buffer that helps maintain your blood's pH within its narrow, healthy range of 7.35 to 7.45. The proximal tubule also secretes substances into the filtrate, adding certain waste products and drugs that were not filtered at the glomerulus. This secretion process helps eliminate toxins and medications more efficiently, supplementing the filtration that occurred upstream in the glomerular capillaries. As filtrate exits the proximal tubule, it enters the loop of Henle, a U-shaped segment that descends deep into the kidney tissue before turning back upward. This structure, named after the 19th century German physician Friedrich Henle, who described it, plays a crucial role in the kidney's ability to produce concentrated urine, conserving water when necessary. The loop of Henle consists of a descending limb and an ascending limb, each with different properties. The descending limb is permeable to water but relatively impermeable to salts. As filtrate descends through this segment, water moves out of the tubule into the surrounding kidney tissue, drawn by the high salt concentration in that tissue. the filtrate becomes increasingly concentrated as it descends, losing water but retaining its dissolved salts and waste products. At the hairpin turn at the bottom of the loop, the tubule's characteristics change dramatically. The ascending limb is impermeable to water, but actively transports salt out of the filtrate and into the surrounding tissue. As filtrate rises through the ascending limb, it loses salt but retains its water, becoming progressively more dilute. This may seem paradoxical, but it creates precisely the conditions the kidney needs to concentrate or dilute urine according to your body's hydration status. The tissue surrounding the loop of Henle, particularly in the kidney's inner region called the medulla, maintains a high salt concentration because of the salt pumped out by the ascending limb. This creates an osmotic gradient, a gradient of concentration that increases with depth into the kidney tissue. When your body needs to conserve water, the filtrate from the ascending limb will eventually flow through collecting ducts that pass through this high salt environment. If these ducts are made permeable to water by hormonal signals, water will move out of the filtrate and back into the body, concentrating the urine. If your body has excess water to eliminate, the collecting ducts remain impermeable and dilute urine is produced. This countercurrent multiplication system, as it's called technically, represents an elegant solution to a complex problem: how to produce urine of varying concentrations depending on the body's needs, all while maintaining blood composition within strict limits. The loop of Henle creates the conditions, but other parts of the nephron and hormonal signals determine how those conditions are used. After ascending through the loop of Henle, filtrate enters the distal convoluted tubule, another coiled segment, this one located back near the glomerulus where the nephron began. The distal tubule performs fine adjustments to the filtrate's composition, responding to hormonal signals that regulate sodium, potassium, calcium, and pH. Where the proximal tubule performed bulk reabsorption, recovering the majority of filtered substances, the distal tubule makes precise adjustments, the final calibrations that ensure blood chemistry remains optimal. Multiple nephrons drain into a single collecting duct, and these collecting ducts merge as they descend through the kidney, eventually emptying into the renal pelvis, a funnel-shaped structure that collects all the urine from all the nephrons in that kidney. From the renal pelvis, urine flows into the ureter and onward to the bladder. This journey from blood to filtrate to urine, from glomerulus through tubule to collecting duct, represents one of the body's most sophisticated processes. At each stage, the composition of the fluid changes. Substances are added or removed. Water is reabsorbed or retained, all under precise regulatory control. And this process repeats continuously, millions of times over across millions of nephrons, creating a steady flow of refined blood returning to circulation and waste-laden urine proceeding toward elimination. But the kidney is more than a passive filter. It is an active participant in maintaining homeostasis, the stable internal environment that allows your cells to function optimally. To understand how the kidney accomplishes this, we need to explore its regulatory mechanisms, the systems of control that allow it to respond to changing conditions. Your kidneys regulate the volume and composition of your blood through several mechanisms. One of the most important involves the renin-angiotensin-aldosterone system, often abbreviated as RAAS, a hormonal cascade that influences blood pressure, blood volume, and sodium balance. When blood pressure drops, or when specialized cells in the kidney sense decreased sodium delivery, the kidney releases an enzyme called renin into the bloodstream. Renin itself doesn't act directly on its targets. Instead, it sets in motion a series of conversions, a molecular cascade that amplifies the initial signal. Renin converts a protein produced by the liver, angiotensinogen, into angiotensin I. Angiotensin I circulates through the bloodstream until it encounters another enzyme, angiotensin-converting enzyme or ACE, found primarily in the lungs but also elsewhere in the body. ACE converts angiotensin I into angiotensin II, and angiotensin II is a powerful actor with multiple effects throughout the body. Angiotensin II constricts blood vessels, increasing resistance to blood flow and thereby raising blood pressure. It stimulates the adrenal glands, small endocrine glands that sit atop each kidney, to release a hormone called aldosterone. Aldosterone acts on the distal tubules and collecting ducts of the nephrons, causing them to increase sodium reabsorption. Where sodium goes, water follows due to osmosis, so increased sodium reabsorption means increased water reabsorption, expanding blood volume and further raising blood pressure. Angiotensin II also stimulates thirst and the release of another hormone, antidiuretic hormone or ADH, from the pituitary gland in the brain. ADH increases the collecting duct's permeability to water, allowing more water to be reabsorbed from the filtrate back into the bloodstream. The combined effects of vasoconstriction, sodium and water retention, and increased fluid intake work together to restore blood pressure and blood volume when they have fallen. This system operates with remarkable sensitivity. The cells that sense sodium delivery to the distal tubule and the cells that sense blood pressure in the kidney's arterioles work together in a structure called the juxtaglomerular apparatus. This cluster of specialized cells monitors conditions and adjusts renin release accordingly, creating a feedback loop that maintains blood pressure within healthy ranges. When blood pressure rises too high, the opposite occurs. Renin release decreases, reducing angiotensin II formation, which leads to vasodilation, decreased aldosterone, and reduced water retention. The kidneys produce more dilute urine in larger volumes, eliminating excess fluid and bringing blood pressure down. Another regulatory mechanism involves atrial natriuretic peptide, or ANP, a hormone released by the heart's atria when they become stretched by excess blood volume. ANP has effects opposite to those of the renin-angiotensin-aldosterone system. It causes vasodilation, inhibits sodium reabsorption in the collecting ducts, and suppresses renin and aldosterone release. The result is increased urine production and decreased blood volume, alleviating the stretch on the heart's atria. These systems work in concert, creating a dynamic balance. When you eat a salty meal, sodium concentration in your blood rises. This triggers thirst, encouraging you to drink more water, but it also inhibits ADH release slightly, allowing your kidneys to excrete more water and eliminate the excess salt. When you exercise vigorously and lose fluid through sweat, blood volume decreases, triggering renin release, angiotensin II formation, aldosterone secretion, and ADH release, all working to conserve water and maintain blood pressure despite your fluid losses. The kidneys also play a crucial role in acid-base balance, maintaining your blood pH within its narrow optimal range. Your cells constantly produce acids as byproducts of metabolism. Carbon dioxide from cellular respiration combines with water to form carbonic acid. Other metabolic processes produce sulfuric acid, phosphoric acid, and various organic acids. Without regulation, these acids would accumulate and lower blood pH, creating a dangerous condition called acidosis. The body employs several buffer systems to manage pH, including the bicarbonate buffer system in the blood and the phosphate and protein buffers within cells. But these buffers can only temporarily neutralize acids. Eventually, the acids must be eliminated, and this is where the kidneys become essential. The kidneys excrete hydrogen ions, the acidic component, into the urine while simultaneously recovering bicarbonate, an alkaline buffer, from the filtrate and returning it to the blood. The cells of the proximal tubule, the loop of Henle, and especially the collecting duct can secrete hydrogen ions actively, using energy to pump them from the cell into the tubule lumen. These hydrogen ions are then trapped in the urine and eliminated from the body. Simultaneously, for every hydrogen ion secreted, the tubule cells can reabsorb or generate a bicarbonate ion and return it to the blood. This effectively removes acid from the body while restoring the buffer capacity of the blood. The kidney can adjust the rate of hydrogen ion secretion and bicarbonate reabsorption based on blood pH, increasing acid excretion when pH falls and decreasing it when pH rises. In this way, the kidneys work alongside the respiratory system, which eliminates carbon dioxide to maintain pH balance. The respiratory system can adjust pH rapidly, within seconds to minutes, by changing breathing rate and depth. The kidneys work more slowly, over hours to days, but they provide the definitive regulation, permanently removing acids or bases from the body as needed. The kidneys also produce and respond to hormones in ways that extend their influence far beyond waste removal and fluid balance. We've already mentioned renin, a hormone enzyme that initiates the RAAS cascade, but the kidneys also produce erythropoietin, a hormone essential for red blood cell production. Erythropoietin is produced by specialized cells in the kidney in response to low oxygen levels in kidney tissue. When oxygen delivery is insufficient, whether because of anemia, low blood oxygen saturation, or inadequate blood flow, the kidneys increase erythropoietin secretion. This hormone travels through the bloodstream to the bone marrow, where it stimulates the production of red blood cells. More red blood cells mean greater oxygen carrying capacity, which helps restore adequate oxygen delivery to tissues, including the kidneys themselves. This creates another feedback loop. As oxygen delivery improves, erythropoietin secretion decreases, preventing overproduction of red blood cells. The system maintains red blood cell numbers within the range necessary for optimal oxygen transport without creating excessive thickness of the blood, which would impede circulation. In chronic kidney disease, when kidney tissue is damaged and cannot produce adequate erythropoietin, anemia often develops. Patients may require synthetic erythropoietin injections to stimulate red blood cell production, compensating for what their damaged kidneys can no longer provide. The kidneys also activate vitamin D, converting it from its inactive form obtained through diet or synthesized in the skin into its active hormonal form, calcitriol. Calcitriol regulates calcium and phosphate metabolism, promoting calcium absorption in the intestines and working with parathyroid hormone to maintain bone health. Without properly functioning kidneys, vitamin D activation is impaired, leading to problems with calcium balance and bone mineralization, conditions often seen in advanced kidney disease. These endocrine functions demonstrate that the kidneys are not merely filters, but integral participants in multiple physiological systems. They influence red blood cell production, bone health, blood pressure regulation, and fluid balance, all while continuously processing blood and producing urine. let us consider the kidney's structure in greater detail, for its architecture reflects its function in beautiful ways. If you were to slice a kidney in half lengthwise, you would see distinct regions, each with its own appearance and role. The outer region, called the cortex, appears granular and reddish-brown due to its rich blood supply. This is where the renal corpuscles and the convoluted tubules reside, where filtration and much of the reabsorption occur. The cortex extends inward in rays called cortical columns that separate the inner structures. Beneath the cortex lies the medulla, organized into triangular structures called renal pyramids. The medulla appears striated, striped, because it contains the parallel loops of Henle and collecting ducts all oriented in the same direction, descending toward the pyramid's tip. The base of each pyramid faces the cortex, while the tip, called the papilla, projects into a space called a minor calyx. The calyces, both minor and major, are cup-like structures that collect urine draining from the collecting ducts. Several minor calyces merge to form major calyces, and these in turn empty into the renal pelvis, the large central collecting space that funnels all urine into the ureter. Blood flow through the kidney follows a specific path that supports the nephron's function. The renal artery branches into segmental arteries, then into interlobar arteries that travel through the cortical columns between the pyramids. These give rise to arcuate arteries that arch along the boundary between cortex and medulla, and from these spring the interlobular arteries that extend outward into the cortex. From the interlobular arteries branch the afferent arterioles, and each afferent arteriole supplies one glomerulus. The term afferent means carrying toward, indicating these vessels bring blood to the glomerulus for filtration. After blood passes through the glomerular capillaries, it exits via the efferent arteriole. Efferent means carrying away, so the efferent arteriole carries blood away from the glomerulus. This arrangement is unusual because normally capillary beds connect an arteriole to a venule. Here we have an arteriole leading to capillaries leading to another arteriole, a portal system that maintains high pressure in the glomerular capillaries, promoting filtration. The efferent arteriole doesn't lead directly to a vein, however. Instead, it branches into a second capillary network, the peritubular capillaries, which surround the convoluted tubules in the cortex, or the vasa recta, long straight vessels that parallel the loops of Henle deep in the medulla. These capillaries pick up the water and solutes reabsorbed from the filtrate, returning them to the general circulation. Eventually, these capillaries drain into venules, then into interlobular veins, arcuate veins, interlobar veins, and finally into the renal vein. When blood pressure rises too high, the opposite occurs. Renin release decreases, reducing angiotensin II formation, which leads to vasodilation, decreased aldosterone, and reduced water retention. The kidneys produce more dilute urine in larger volumes, eliminating excess fluid and bringing blood pressure down. Another regulatory mechanism involves atrial natriuretic peptide, or ANP, a hormone released by the heart's atria when they become stretched by excess blood volume. ANP has effects opposite to those of the renin-angiotensin-aldosterone system. It causes vasodilation, inhibits sodium reabsorption in the collecting ducts, and suppresses renin and aldosterone release. The result is increased urine production and decreased blood volume, alleviating the stretch on the heart's atria. These systems work in concert, creating a dynamic balance. When you eat a salty meal, sodium concentration in your blood rises. This triggers thirst, encouraging you to drink more water, but it also inhibits ADH release slightly, allowing your kidneys to excrete more water and eliminate the excess salt. When you exercise vigorously and lose fluid through sweat, blood volume decreases, triggering renin release, angiotensin II formation, aldosterone secretion, and ADH release, all working to conserve water and maintain blood pressure despite your fluid losses. The kidneys also play a crucial role in acid-base balance, maintaining your blood pH within its narrow optimal range. Your cells constantly produce acids as byproducts of metabolism. Carbon dioxide from cellular respiration combines with water to form carbonic acid. Other metabolic processes produce sulfuric acid, phosphoric acid, and various organic acids. Without regulation, these acids would accumulate and lower blood pH, creating a dangerous condition called acidosis. The body employs several buffer systems to manage pH, including the bicarbonate buffer system in the blood and the phosphate and protein buffers within cells. But these buffers can only temporarily neutralize acids. Eventually, the acids must be eliminated, and this is where the kidneys become essential. The kidneys excrete hydrogen ions, the acidic component, into the urine while simultaneously recovering bicarbonate and alkaline buffer from the filtrate and returning it to the blood. The cells of the proximal tubule, the loop of Henle, and especially the collecting duct can secrete hydrogen ions actively, using energy to pump them from the cell into the tubule lumen. These hydrogen ions are then trapped in the urine and eliminated from the body. Simultaneously, for every hydrogen ion secreted, the tubule cells can reabsorb or generate a bicarbonate ion and return it to the blood. This effectively removes acid from the body while restoring the buffer capacity of the blood. The kidney can adjust the rate of hydrogen ion secretion and bicarbonate reabsorption based on blood pH, increasing acid excretion when pH falls and decreasing it when pH rises. In this way, the kidneys work alongside the respiratory system, which eliminates carbon dioxide to maintain pH balance. The respiratory system can adjust pH rapidly, within seconds to minutes, by changing breathing rate and depth. The kidneys work more slowly, over hours to days, but they provide the definitive regulation, permanently removing acids or bases from the body as needed. The kidneys also produce and respond to hormones in ways that extend their influence far beyond waste removal and fluid balance. We've already mentioned renin, a hormone enzyme that initiates the RAS cascade. But the kidneys also produce erythropoietin, a hormone essential for red blood cell production. Erythropoietin is produced by specialized cells in the kidney in response to low oxygen levels in kidney tissue. When oxygen delivery is insufficient, whether because of anemia, low blood oxygen saturation, or inadequate blood flow, the kidneys increase erythropoietin secretion. This hormone travels through the bloodstream to the bone marrow, where it stimulates the production of red blood cells. More red blood cells mean greater oxygen carrying capacity, which helps restore adequate oxygen delivery to tissues, including the kidneys themselves. This creates another feedback loop. As oxygen delivery improves, erythropoietin secretion decreases, preventing overproduction of red blood cells. The system maintains red blood cell numbers within the range necessary for optimal oxygen transport, without creating excessive thickness of the blood, which would impede circulation. In chronic kidney disease, when kidney tissue is damaged and cannot produce adequate erythropoietin, anemia often develops. Patients may require synthetic erythropoietin injections to stimulate red blood cell production. compensating for what their damaged kidneys can no longer provide. The kidneys also activate vitamin D, converting it from its inactive form, obtained through diet or synthesized in the skin, into its active hormonal form, calcitriol. Calcitriol regulates calcium and phosphate metabolism, promoting calcium absorption in the intestines and working with parathyroid hormone to maintain bone health. Without properly functioning kidneys, vitamin D activation is impaired, leading to problems with calcium balance and bone mineralization, conditions often seen in advanced kidney disease. These endocrine functions demonstrate that the kidneys are not merely filters, but integral participants in multiple physiological systems. They influence red blood cell production, bone health, blood pressure regulation, and fluid balance, all while continuously processing blood and producing urine. Let us consider the kidney structure in greater detail, for its architecture reflects its function in beautiful ways. If you were to slice a kidney in half lengthwise, you would see distinct regions, each with its own appearance and role. The outer region, called the cortex, appears granular and reddish-brown due to its rich blood supply. This is where the renal corpuscles and the convoluted tubules reside, where filtration and much of the reabsorption occur. The cortex extends inward in rays called cortical columns that separate the inner structures. Beneath the cortex lies the medulla, organized into triangular structures called renal pyramids. The medulla appears striated, striped, because it contains the parallel loops of Henle and collecting ducts all oriented in the same direction, descending toward the pyramid's tip. The base of each pyramid faces the cortex, while the tip, called the papilla, projects into a space called a minor calyx. The calyces, both minor and major, are cup-like structures that collect urine draining from the collecting ducts. Several minor calyces merge to form major callus, and these in turn empty into the renal pelvis, the large central collecting space that funnels all urine into the ureter. Blood flow through the kidney follows a specific path that supports the nephron's function. The renal artery branches into segmental arteries, then into interlobar arteries that travel through the cortical columns between the pyramids. These give rise to arcuate arteries that arch along the boundary between cortex and medulla, and from these spring the interlobular arteries that extend outward into the cortex. From the interlobular arteries branch the afferent arterioles, and each afferent arteriole supplies one glomerulus. The term afferent means carrying toward, indicating these vessels bring blood to the glomerulus for filtration. After blood passes through the glomerular capillaries, it exits via the efferent arteriole. Efferent means carrying away, so the efferent arteriole carries blood away from the glomerulus. This arrangement is unusual because normally capillary beds connect an arteriole to a venule. Here, we have an arteriole leading to capillaries, leading to another arteriole, a portal system that maintains high pressure in the glomerular capillaries, promoting filtration. The efferent arteriole doesn't lead directly to a vein, however. Instead, it branches into a second capillary network, the paratubular capillaries, which surround the convoluted tubules in the cortex, or the vasa recta, long straight vessels that parallel the loops of Henle deep in the medulla. These capillaries pick up the water and solutes reabsorbed from the filtrate, returning them to the general circulation. Eventually, these capillaries drain into venules, then into interlobular veins, arcuate veins, interlobar veins, and finally into the renal vein. This dual capillary system, glomerular capillaries for filtration and peritubular capillaries for reabsorption, allows the kidney to process enormous volumes of fluid without losing valuable substances. It's an elegant solution to the challenge of filtering blood comprehensively while retaining what the body needs. The nephrons themselves are not all identical. Nephrons whose glomeruli sit in the outer cortex are called cortical nephrons and have relatively short loops of Henle. Nephrons whose glomeruli lie near the corticomedullary junction, the boundary between cortex and medulla, are called juxtamedullary nephrons and have very long loops of Henle that descend deep into the medulla. These juxtamedullary nephrons, though they comprise only about 15% of all nephrons, are crucial for creating the concentrated urine that allows the kidney to conserve water effectively. As we move deeper into understanding the kidney's function, we encounter the concept of glomerular filtration rate, often abbreviated as GFR. This is the volume of filtrate formed by all the glomeruli in both kidneys per unit of time, typically expressed as milliliters per minute. A normal GFR is approximately 125 milliliters per minute in a healthy adult, though this varies with age, sex, and body size. GFR is determined by several factors: the hydrostatic pressure in the glomerular capillaries, which pushes fluid out, the hydrostatic pressure in Bowman's capsule, which opposes filtration, and the osmotic pressure gradient created by proteins remaining in the blood, which also opposes filtration by drawing water back into the capillaries. The net filtration pressure is the sum of these forces, and it drives the formation of filtrate. The kidneys can regulate GFR through several mechanisms. Constricting or dilating the afferent and efferent arterioles changes the pressure in the glomerular capillaries. Constricting the afferent arteriole reduces blood flow to the glomerulus and decreases GFR. Constricting the efferent arteriole increases pressure in the glomerulus, raising GFR, though extreme constriction would eventually reduce blood flow enough to lower GFR. These adjustments occur through both intrinsic and extrinsic mechanisms. Intrinsic mechanisms include the myogenic response, where the smooth muscle in arterial walls responds directly to pressure changes, contracting when stretched to prevent excessive pressure from reaching the glomerulus. There's also tubular-glomerular feedback, where the juxtaglomerular apparatus senses the sodium concentration in the filtrate at the distal tubule and adjusts afferent arterial tone accordingly. Extrinsic mechanisms involve the sympathetic nervous system and hormones. During stress or exercise, sympathetic activation constricts afferent arterioles, reducing GFR and conserving blood for skeletal muscles and vital organs. Angiotensin II constricts both afferent and efferent arterioles, but affects the efferent more strongly, which helps maintain GFR even when blood pressure falls, preserving kidney function during hypotension. These regulatory mechanisms ensure that GFR remains relatively constant despite fluctuations in blood pressure, a phenomenon called autoregulation. Within a blood pressure range of approximately 80 to 180 millimeters of mercury, the kidneys maintain stable GFR, protecting the filtration apparatus from damage that would result from excessive pressure while ensuring adequate urine formation even when blood pressure dips somewhat. Understanding GFR is clinically important because it reflects kidney function. When GFR declines, it indicates that the kidneys are losing their ability to filter blood effectively, a sign of kidney disease. Nephrologists use estimated GFR calculated from blood creatinine levels and demographic factors to stage chronic kidney disease and guide treatment decisions. Now let us turn our attention to the specific substances the kidneys handle and how they manage each one. We've mentioned water, sodium, glucose, and amino acids, but the kidneys regulate dozens of substances, each requiring specific transport mechanisms and regulatory controls. Sodium is perhaps the most important electrolyte the kidneys regulate because sodium content largely determines extracellular fluid volume. Approximately 99% of filtered sodium is reabsorbed along the nephron. The proximal tubule reabsorbs about 65%, the loop of Henle another 25%, and the distal tubule and collecting duct the remaining 10% or so. This final 10% is under hormonal control, primarily by aldosterone, allowing fine-tuning of sodium balance and consequently blood volume and pressure. Potassium balance is equally critical because even small deviations in blood potassium concentration can affect heart rhythm and muscle function. The kidneys filter potassium freely, reabsorb most of it in the proximal tubule and loop of Henle, and then secrete it in the distal tubule and collecting duct under aldosterone's influence. This secretion is the primary mechanism for eliminating excess potassium, particularly important after a potassium-rich meal. Calcium regulation involves the kidneys, bones, intestines, and parathyroid glands in a complex interplay. About 99% of filtered calcium is reabsorbed, mostly in the proximal tubule and loop of Henle. Parathyroid hormone increases calcium reabsorption in the distal tubule, raising blood calcium when levels fall. The kidneys also activate vitamin D, which enhances intestinal calcium absorption and works with parathyroid hormone on bone to mobilize calcium stores when needed. Phosphate handling links to calcium metabolism because these ions tend to have an inverse relationship in the blood. The kidneys reabsorb approximately 80% of filtered phosphate in the proximal tubule. Parathyroid hormone inhibits this reabsorption, increasing phosphate excretion when calcium needs to rise, since calcium and phosphate can precipitate together if both are elevated simultaneously. Magnesium, another important electrolyte, is reabsorbed primarily in the loop of Henle. The kidneys adjust magnesium excretion to match intake, maintaining stable blood levels necessary for enzyme function, nerve transmission, and muscle contraction. The kidneys also excrete metabolic waste products, substances generated by the breakdown of proteins, nucleic acids, and other molecules. Urea, formed in the liver from ammonia produced during amino acid metabolism, is the primary nitrogenous waste in urine. About 50% of filtered urea is excreted, with the remainder being reabsorbed passively along the nephron. Urea actually plays a role in the concentrating mechanism, contributing to the high osmolality of the inner medulla that allows water reabsorption from the collecting ducts. Creatinine, a breakdown product of creatine phosphate in muscle, is filtered freely and not significantly reabsorbed or secreted, making it an ideal marker for estimating GFR. Measuring blood creatinine levels and calculating clearance gives clinicians insight into kidney function. Uric acid, the end product of purine metabolism, is filtered, reabsorbed, secreted, and reabsorbed again at different points along the nephron, a complex handling that allows for fine regulation. Elevated uric acid levels can lead to gout, while very low levels can occur with certain medications or kidney disorders. The kidneys also eliminate drugs and toxins. Many medications are filtered at the glomerulus, and some are actively secreted into the tubule lumen by transporters in the proximal tubule. This is why kidney function is crucial when dosing medications. Impaired kidneys may not clear drugs adequately, leading to accumulation and toxicity. Conversely, some drugs can be nephrotoxic, damaging kidney tissue, requiring careful monitoring when they're used. With all these substances to regulate, all these processes occurring simultaneously across millions of nephrons, the kidney functions as an extraordinarily complex chemical plant. And yet it accomplishes this complexity with such reliability that we remain largely unaware of its constant work. Only when kidney function declines do we begin to appreciate how much we depend on these quiet organs. Let us consider what happens when kidney function is compromised. Acute kidney injury, formerly called acute renal failure, involves a sudden decline in kidney function over hours to days. This can result from decreased blood flow to the kidneys, as in severe dehydration, bleeding, or heart failure. From direct damage to kidney tissue, as with certain toxins, medications, or infections. Or from obstruction of urine flow, as with kidney stones or an enlarged prostate. In acute kidney injury, GFR drops, waste products accumulate in the blood, fluid and electrolyte balance becomes disturbed, and acid-base regulation falters. Urea and creatinine levels rise. Potassium may accumulate to dangerous levels. Fluid retention can lead to swelling and, if severe, to pulmonary edema, fluid in the lungs. The kidneys may produce very little urine, a condition called oliguria, or sometimes no urine at all, anuria. Treatment focuses on addressing the underlying cause, supporting the patient through the acute phase, and preventing complications. In severe cases, dialysis may be necessary temporarily to remove waste products and excess fluid, giving the kidneys time to recover. Many cases of acute kidney injury are reversible if treated promptly, though severe or prolonged injury can lead to lasting damage. Chronic kidney disease develops over months to years and represents progressive permanent loss of kidney function. Common causes include diabetes, hypertension, glomerular diseases, and polycystic kidney disease. As nephrons are damaged and lost, the remaining nephrons adapt, increasing their individual filtration rates to compensate. This adaptation can maintain near normal kidney function even with significant nephron loss, which is why chronic kidney disease often goes undetected until it's advanced. Eventually, compensatory mechanisms fail. GFR declines, waste products accumulate, and the kidneys can no longer regulate fluid, electrolyte, and acid-base balance effectively. Patients may develop anemia from decreased erythropoietin production, bone disease from impaired vitamin D activation and phosphate retention, and cardiovascular complications from hypertension and fluid overload. Chronic kidney disease is staged based on GFR from stage 1, where damage is present but GFR is normal or elevated, through stage 5, kidney failure, where GFR falls below 15 and dialysis or transplantation becomes necessary for survival. Managing chronic kidney disease involves controlling underlying conditions like diabetes and hypertension, avoiding nephrotoxic substances, dietary modifications to reduce the burden on remaining kidney function, and medications to manage complications. When kidneys fail completely, renal replacement therapy becomes necessary. Hemodialysis uses a machine to pump blood through a filter outside the body, removing waste products and excess fluid before returning the clean blood to the patient. This typically requires sessions 3 times per week, each lasting several hours. Peritoneal dialysis uses the patient's own peritoneal membrane, the lining of the abdominal cavity, as a filter. A solution is infused into the abdomen. Waste products and excess fluid move from blood vessels into this solution, and then the solution is drained out. This can be done continuously or in multiple exchanges throughout the day. Kidney transplantation offers the best outcomes for suitable candidates, replacing failed kidneys with a healthy organ from a deceased or living donor. A transplanted kidney can restore nearly normal kidney function, freeing patients from dialysis and greatly improving quality of life, though immunosuppressive medications are required lifelong to prevent rejection. Understanding kidney disease helps us appreciate the kidney's normal function. These organs are resilient, with tremendous reserve capacity, but they're also vulnerable to damage from high blood pressure, diabetes, toxins, infections, and inadequate blood flow. Protecting kidney health involves managing chronic conditions, avoiding nephrotoxic substances, staying hydrated, and maintaining overall cardiovascular health. As we reach the transition point in our journey, notice how the kidneys emerge as central players in maintaining your body's internal stability. They are not isolated organs, but nodes in a vast network of regulatory systems. They respond to hormones from the brain, the heart, and the adrenal glands. They produce hormones that influence bone marrow, bone tissue, blood vessels, and electrolyte balance throughout the body. They work in concert with the lungs to regulate pH, with the cardiovascular system to maintain blood pressure, with the liver to process and eliminate toxins. The renal system exemplifies integration, showing how one organ system participates in multiple physiological processes simultaneously. Even now, as you rest here, your kidneys are reading your blood's composition, making thousands of adjustments each second, maintaining you in balance. They filter and reabsorb, secrete and concentrate, producing urine that reflects your body's needs in this moment, different from what it will be in an hour, different from what it was this morning, constantly adapting to keep your internal environment stable despite the changing external world. We have explored the foundations, the anatomy of the renal system, the structure and function of the nephron, the processes of filtration and reabsorption, the hormonal and neural regulation that allows kidneys to respond to changing conditions, and the clinical significance when kidney function declines. We have seen how kidneys manage water and electrolytes, excrete wastes, regulate blood pressure, produce hormones, and maintain acid-base balance. In the sections that follow, we will delve deeper into specific regulatory mechanisms, explore the clinical assessment of kidney function, examine common kidney disorders in greater detail, and appreciate the research frontiers that promise to improve our understanding and treatment of kidney disease. But for now, rest in the knowledge that your kidneys are working beautifully, performing their intricate chemical choreography without requiring any conscious effort from you, maintaining the precise conditions that allow every other cell in your body to function optimally. We return now to the kidneys, those paired guardians of your internal chemistry, and we deepen our exploration. In the first part of our journey, we establish the foundation, the architecture of the renal system, the elegance of the nephron, the basic processes of filtration and reabsorption. We saw how these organs maintain fluid balance, regulate electrolytes, control blood pressure, and eliminate waste products. Now we turn our attention to the intricate details, the specialized mechanisms and regulatory pathways that make the kidney one of the body's most sophisticated organs. The kidney's work continues in this very moment, adjusting and adapting, responding to signals from throughout your body. As we explore these deeper mechanisms, allow the information to settle naturally, like sediment finding its level in still water. There is no urgency here, only the gradual unfolding of understanding. Let us begin with the concept of clearance, a principle fundamental to understanding how kidneys process different substances. Clearance refers to the volume of plasma from which a substance is completely removed per unit of time. It's a way of quantifying how efficiently the kidneys handle specific compounds, and it varies dramatically depending on the substance in question. Consider inulin, a plant-derived polysaccharide sometimes used in research. Inulin is filtered freely at the glomerulus, meaning it passes through the filtration barrier as easily as water, but it is neither reabsorbed nor secreted anywhere along the nephron. Every molecule of inulin that enters the filtrate eventually appears in the urine. Because of this, inulin clearance equals the glomerular filtration rate. Measuring how quickly the kidneys clear inulin from the blood gives us a precise measure of GFR. Though in clinical practice, this test is rarely performed because it requires continuous intravenous infusion and careful urine collection. Instead, clinicians use creatinine, which behaves similarly to inulin. Creatinine is produced at a relatively constant rate by muscle metabolism, filtered freely at the glomerulus, and mostly not reabsorbed, though small amounts are secreted in the proximal tubule. Creatinine clearance provides a good estimate of GFR, calculated from a 24-hour urine collection and a blood sample, or estimated from blood creatinine levels using equations that account for age, sex, race, and body size. Other substances have clearances different from GFR. Glucose, under normal circumstances, has a clearance of 0 because it's completely reabsorbed. Nothing is cleared from the plasma. Urea has a clearance lower than GFR because about half of filtered urea is reabsorbed. Para-aminohippuric acid, or PAH, another research compound, is not only filtered but also secreted so completely by the proximal tubule that nearly all PAH is removed from the blood passing through the kidneys in a single pass. PA clearance therefore approximates renal plasma flow, the rate at which plasma flows through the kidneys. Understanding clearance helps us appreciate how the kidney treats different substances selectively. It's not simply a filter that retains large molecules and passes small ones. It actively chooses what to reclaim, what to eliminate, and what to add to the filtrate through secretion, all based on the body's immediate needs. The proximal tubule, which we introduced earlier as the site of bulk reabsorption, deserves closer examination because it performs an astonishing amount of work. Approximately 65% of filtered water and sodium return to the bloodstream here, along with nearly all glucose, amino acids, and bicarbonate. The cells lining the proximal tubule are among the most metabolically active in the body, reflecting the energy required for this massive reabsorption. These cells possess two distinct surfaces: the apical membrane facing the tubule lumen and the filtrate, and the basolateral membrane facing the interstitial fluid and the peritubular capillaries. Each membrane contains different transport proteins, creating directional transport from lumen to blood. Sodium reabsorption drives much of the proximal tubule's function. The basolateral membrane contains sodium-potassium ATPase pumps, enzymes that use ATP energy to pump sodium out of the cell into the interstitial fluid while pumping potassium in. This creates a low sodium concentration inside the cell. Sodium then moves from the tubule lumen into the cell down its concentration gradient through various transporters on the apical membrane. Some sodium enters through sodium-hydrogen exchangers, which move sodium in while moving hydrogen ions out into the lumen. Others enter with glucose, amino acids, or phosphate through co-transporters that move multiple substances together. As sodium is transported from lumen to blood, it creates an osmotic gradient that draws water along, primarily through aquaporin 1 water channels that span the cell membranes. This water movement is passive, driven by osmosis, but it depends on the active sodium transport that creates the osmotic gradient. Water can also move between cells through tight junctions, the connections between adjacent epithelial cells, which in the proximal tubule are relatively leaky. Glucose reabsorption occurs through sodium-glucose cotransporters on the apical membrane. These proteins bind both sodium and glucose simultaneously and transport both into the cell. The sodium gradient created by the basolateral sodium-potassium ATPase provides the energy for glucose transport. Once inside the cell, glucose exits through the basolateral membrane via facilitated diffusion through GALUT transporters, moving into the interstitial fluid and then into the peritubular capillaries. This system has a maximum capacity determined by the number of transporters available. When blood glucose exceeds approximately 180 to 200 milligrams per deciliter, the filtered load of glucose exceeds the proximal tubule's reabsorptive capacity, and glucose appears in the urine. This threshold is called the renal threshold for glucose, and its exceedance indicates that blood glucose has risen beyond normal range, as occurs in uncontrolled diabetes mellitus. Amino acids are reabsorbed through similar sodium-coupled mechanisms with different transporters for different amino acid classes. Nearly complete reabsorption occurs in the proximal tubule, preventing the loss of these valuable protein building blocks. Rare genetic disorders affecting specific amino acid transporters can cause aminoaciduria, the presence of certain amino acids in urine, though these conditions are usually benign if they affect only amino acids that the body can synthesize or obtain adequately from diet. Bicarbonate reabsorption is essential for maintaining acid-base balance. Bicarbonate cannot cross cell membranes directly, so the proximal tubule employs an indirect mechanism. Hydrogen ions secreted into the lumen via sodium-hydrogen exchangers combine with filtered bicarbonate to form carbonic acid. An enzyme called carbonic anhydrase, present on the apical membrane surface, catalyzes the conversion of carbonic acid into carbon dioxide and water. Carbon dioxide diffuses freely into the tubule cell, where intracellular carbonic anhydrase catalyzes the reverse reaction, producing carbonic acid again, which dissociates into hydrogen ions and bicarbonate. The bicarbonate exits the cell through the basolateral membrane via cotransporters, returning to the blood while the hydrogen ion is available for secretion again. This process effectively reclaims filtered bicarbonate, preventing the loss of this important buffer. The proximal tubule reabsorbs approximately 80 to 90% of filtered bicarbonate, with the remainder recovered in other nephron segments. The proximal tubule also secretes substances into the filtrate. Organic anions and organic cations, including many drugs, toxins, and metabolic byproducts, are actively secreted here. Specific transporters on the apical and basolateral membranes move these substances from the peritubular capillaries into the cells and then into the tubule lumen. This secretion supplements the filtration that occurred at the glomerulus, enhancing the kidney's ability to eliminate these compounds. Some medications compete for these secretory pathways. Probenecid, for instance, inhibits the secretion of uric acid, and certain antibiotics, like penicillin, originally used to prolong penicillin's action by slowing its elimination. Probenecid is now more commonly used to treat gout by increasing uric acid excretion, though the mechanism involves complex effects on multiple transporters. As filtrate exits the proximal tubule and enters the loop of Henle, its composition has already changed dramatically. About 65% of the filtered water and sodium have been reabsorbed, along with all the glucose and amino acids, most of the bicarbonate, and significant amounts of potassium, calcium, and phosphate. What remains is a smaller volume containing waste products like urea and creatinine at higher concentrations than in the original filtrate. The loop of Henle, that U-shaped structure descending into the kidney's medulla and then ascending back toward the cortex, performs a function that initially seems counterintuitive but proves essential. It creates the conditions necessary for producing concentrated urine, yet in doing so, it produces dilute fluid in its own lumen. The descending limb, as we mentioned earlier, is permeable to water but relatively impermeable to solutes. As filtrate descends, it passes through regions of increasing osmolality in the surrounding medullary interstitium. Water moves out of the descending limb by osmosis, drawn by the high solute concentration outside. The filtrate becomes progressively more concentrated as it descends, potentially reaching osmolalities of 1200 to 1400 milliosmoles per kilogram at the hairpin turn in the deepest part of the medulla, compared to about 300 milliosmoles per kilogram in the cortex and in plasma. At the turn, the tubule's properties change. The ascending limb is impermeable to water but actively transports sodium, potassium, and chloride out of the lumen into the surrounding interstitium. The thick ascending limb, which begins partway up from the turn, contains sodium-potassium chloride cotransporters that move all three ions together from the lumen into the tubule cells. Sodium is then pumped out the basolateral side by sodium-potassium ATPase, while potassium and chloride exit through channels, all moving into the interstitial fluid. This active solute reabsorption without water reabsorption dilutes the filtrate. By the time fluid exits the loop of Henle at the top of the ascending limb, it has become hypotonic, with an osmolality around 100 to 150 milliosmoles per kilogram, even more dilute than plasma. Meanwhile, the solutes pumped out into the medullary interstitium accumulate, creating and maintaining the high osmolality that drew water out of the descending limb. This is the countercurrent multiplier system. Countercurrent because fluid flows in opposite directions in the two limbs, descending in one and ascending in the other. Multiplier because the system amplifies a relatively modest single effect. The transport of solutes by the ascending limb into a large osmotic gradient from cortex to medulla. The vasa recta, the long straight capillaries that parallel the loops of Henle, also operate as a countercurrent exchanger. Blood descending into the medulla encounters increasing osmolality, causing water to leave the blood and solutes to enter. Blood ascending back toward the cortex encounters decreasing osmolality, so water re-enters the blood and solutes leave. This countercurrent exchange allows the vasa recta to remove the water reabsorbed from the descending limb and supply the blood flow necessary for tubule cell function without washing away the medullary osmotic gradient. The result is a standing osmotic gradient in the medullary interstitium, increasing from the corticomedullary junction toward the papillary tip. This gradient is essential for water reabsorption in the collecting ducts. When collecting ducts pass through this high osmolality environment and are made permeable to water by hormonal signals, water moves out of the duct lumen and into the interstitium, concentrating the urine. When the collecting ducts remain impermeable to water, the dilute fluid from the ascending limb passes through unchanged, and dilute urine is excreted. The hormone that regulates collecting duct water permeability is antidiuretic hormone, also called vasopressin or ADH. Produced by neurons in the hypothalamus and released from the posterior pituitary gland, ADH responds to changes in plasma osmolality and blood volume. When plasma becomes too concentrated, osmoreceptors in the hypothalamus detect this and trigger ADH release. When blood volume or pressure falls, baroreceptors in the cardiovascular system signal for ADH release as well. ADH travels through the bloodstream to the kidneys, where it binds to receptors on the basolateral membrane of collecting duct cells. This triggers a signaling cascade within the cell that causes vesicles containing aquaporin II water channels to move to and fuse with the apical membrane. With these channels in place, water can move from the duct lumen through the cell and out into the medullary interstitium, drawn by the high osmolality there. From the interstitium, water enters the vasa recta and returns to the circulation. When ADH levels fall, the aquaporin II channels are removed from the apical membrane through endocytosis. The membrane pinches inward to recapture the channels, and water permeability decreases. Without water reabsorption, the dilute fluid from the loop of Henle passes through the collecting ducts relatively unchanged, and large volumes of dilute urine are produced. This explains why alcohol consumption increases urine production. Alcohol inhibits ADH release, reducing collecting duct water permeability and causing the kidneys to excrete more water, leading to dehydration despite fluid intake. It also explains diabetes insipidus, a condition distinct from diabetes mellitus, where ADH is either not produced in adequate amounts, central diabetes insipidus, or the kidneys don't respond to it, nephrogenic diabetes insipidus. Patients produce enormous volumes of very dilute urine, sometimes 10 to 15 liters daily, and experience intense thirst as the body attempts to replace the lost water. The distal convoluted tubule and the collecting duct together perform the final adjustments to urine composition, fine-tuning electrolyte balance in response to hormonal signals. We've discussed aldosterone's effects on sodium reabsorption. Let us explore this in greater detail. Aldosterone, a mineralocorticoid hormone produced by the adrenal cortex, acts primarily on the principal cells of the late distal tubule and collecting duct. It increases the synthesis and insertion of sodium channels in the apical membrane and sodium-potassium ATPase pumps in the basolateral membrane. More sodium channels mean more sodium can enter the cell from the lumen, and more sodium-potassium pumps mean more sodium can be moved from the cell into the blood. The net effect is increased sodium reabsorption. As sodium is reabsorbed, it creates a negative electrical potential in the tubule lumen relative to the cell interior, because positive charges are being removed. This electrical gradient drives the secretion of potassium through potassium channels in the apical membrane. So aldosterone simultaneously increases sodium reabsorption and potassium secretion, which is why excess aldosterone can cause hypokalemia. low blood potassium, while aldosterone deficiency can cause hyperkalemia, elevated potassium. The collecting duct also contains intercalated cells, which come in two types. Type A intercalated cells secrete hydrogen ions and reabsorb bicarbonate, contributing to acid excretion. Type B intercalated cells do the opposite, secreting bicarbonate and reabsorbing hydrogen ions, contributing to base excretion when needed, though they're less active under normal conditions. This allows the kidney to adjust acid-base balance in the final stages of urine formation. Hydrogen ion secretion in the collecting duct can occur against very steep concentration gradients, allowing the urine to become quite acidic, with a pH as low as 4.5 compared to blood pH of 7.4. This remarkable ability to concentrate hydrogen ions requires active transport through specialized proton pumps, enzymes that use ATP energy to move hydrogen ions from cell to lumen, even when the lumen is already much more acidic than the cell. The secreted hydrogen ions must be buffered in the urine to prevent the pH from falling so low that it damages the urinary tract. Phosphate buffers, particularly monohydrogen phosphate, accepting a hydrogen ion to become dihydrogen phosphate, provide significant buffering capacity. When hydrogen ion secretion is very high, such as during metabolic acidosis, the kidney also produces ammonia from the amino acid glutamine. Ammonia combines with hydrogen ions to form ammonium, which is trapped in the acidic urine and excreted. This ammonia production and ammonium excretion allow the kidney to eliminate large amounts of acid without the urine pH dropping to damaging levels. Through these mechanisms in the collecting duct, the kidney makes final adjustments, sometimes reabsorbing additional sodium and water when aldosterone and ADH levels are high, sometimes secreting more potassium or hydrogen ions, sometimes allowing dilute urine to pass through when ADH is low. The result is urine precisely matched to the body's current state, reflecting the integration of multiple regulatory signals. Let us now consider the juxtaglomerular apparatus in greater detail, for this structure exemplifies how the kidney monitors its own function and responds to systemic needs. Located where the distal tubule contacts the glomerulus from which it arose, the juxtaglomerular apparatus consists of specialized cells in three locations: the macula densa, part of the distal tubule wall; the juxtaglomerular cells, modified smooth muscle cells in the afferent arterial wall; and the extraglomerular mesangial cells, supporting cells between the arterioles and tubule. The macula densa cells sense the sodium chloride concentration in the distal tubule fluid flowing past them. When sodium chloride delivery to the distal tubule decreases, perhaps because of reduced GFR or increased proximal reabsorption, the macula densa cells signal the juxtaglomerular cells to release renin. They also signal the afferent arteriole to dilate, increasing blood flow to the glomerulus and raising GFR. This is tubuloglomerular feedback, a mechanism that helps stabilize GFR and ensure adequate sodium delivery to the distal nephron. When sodium chloride delivery increases, the macula densa senses this and suppresses renin release while causing afferent arterial constriction, reducing GFR. This prevents excessive filtration that might overwhelm the tubule's reabsorptive capacity. The juxtaglomerular cells themselves sense pressure in the afferent arteriole through stretch receptors. When blood pressure falls, the arteriole wall is less stretched, and this directly stimulates renin release, independent of macula densa signaling. Conversely, elevated blood pressure stretches the arteriole wall more, inhibiting renin release. Renin release is also stimulated by sympathetic nervous system activation, which occurs during stress, exercise, or hypovolemia. Beta-adrenergic receptors on juxtaglomerular cells respond to norepinephrine and epinephrine, triggering renin secretion even when blood pressure and sodium delivery appear adequate. Once released, renin initiates the cascade we described earlier. Conversion of angiotensinogen to angiotensin I, then conversion by ACE to angiotensin II. Angiotensin II has multiple effects. It constricts blood vessels throughout the body, raising systemic blood pressure. It preferentially constricts the efferent arteriole of the glomerulus, increasing glomerular capillary pressure and helping maintain GFR even when systemic blood pressure has fallen. It stimulates aldosterone release from the adrenal cortex, promoting sodium and water retention. It stimulates ADH release from the posterior pituitary, enhancing water reabsorption in the collecting ducts. It triggers thirst, encouraging fluid intake. And it stimulates the proximal tubule to increase sodium and water reabsorption directly. All these effects work together to restore blood volume and blood pressure when they've fallen, demonstrating the kidney's central role in cardiovascular regulation. The renin-angiotensin-aldosterone system is one of the body's most powerful blood pressure regulatory mechanisms, and many antihypertensive medications target components of this system. ACE inhibitors block the conversion of angiotensin I to angiotensin II. Angiotensin receptor blockers prevent angiotensin II from binding to its receptors. Both reduce blood pressure by preventing angiotensin II's multiple effects. Aldosterone antagonists, like spironolactone, block aldosterone's effects on the collecting duct, reducing sodium and water retention, and also reducing potassium excretion, making them potassium-sparing diuretics. These medications are used not only for hypertension, but also for conditions like heart failure, where fluid retention is problematic. The kidney's relationship with blood pressure is bidirectional. High blood pressure can damage the kidneys over time, particularly the glomerular capillaries, leading to chronic kidney disease. Damaged kidneys often struggle to regulate blood pressure effectively, which can create a vicious cycle of worsening hypertension and progressive kidney damage. This is why managing blood pressure is crucial for kidney health, and why kidney disease often complicates blood pressure management. Let us turn now to the kidney's role in calcium and phosphate metabolism, an area that connects the kidneys to bone health, parathyroid function, and vitamin D activation. Calcium is essential for bone mineralization, muscle contraction, nerve transmission, blood clotting, and numerous enzymatic reactions. The body maintains blood calcium concentration within a narrow range, and the kidneys play a central role in this regulation. About 99% of filtered calcium is reabsorbed along the nephron. The proximal tubule reabsorbs approximately 60 to 70% through passive paracellular transport, calcium moving between cells along with water and sodium. The thick ascending limb of the loop of Henle reabsorbs another 20% through a combination of paracellular and transcellular routes. The distal tubule performs the fine regulation, reabsorbing 10 to 15% under the control of parathyroid hormone. Parathyroid hormone, or PTH, is secreted by the parathyroid glands when blood calcium levels fall. PTH has three main effects that raise blood calcium. First, it increases calcium reabsorption in the distal tubule by promoting the insertion of calcium channels into the apical membrane and calcium transporters into the basolateral membrane. Second, it stimulates bone resorption, the breakdown of bone tissue by osteoclasts, releasing calcium and phosphate from bone mineral into the blood. Third, it activates vitamin D in the kidney, which then increases intestinal calcium absorption. Vitamin D itself undergoes a two-step activation process. Ultraviolet radiation converts 7-dehydrocholesterol in the skin to cholecalciferol. Vitamin D3 or vitamin D can be obtained from dietary sources. The liver converts this to 25-hydroxyvitamin D. The kidneys perform the final activation step, converting 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D, the active hormonal form also called calcitriol. This conversion occurs in the proximal tubule cells under the influence of PTH. Calcitriol increases calcium absorption in the intestines by promoting the synthesis of calcium-binding proteins and calcium transporters in intestinal epithelial cells. It also works with PTH to mobilize calcium from bone when necessary and has direct effects on the kidney to enhance calcium reabsorption. Calcitriol feeds back to suppress PTH secretion when calcium levels are restored, creating a regulatory loop. Phosphate handling interacts with calcium metabolism. PTH inhibits phosphate reabsorption in the proximal tubule, increasing phosphate excretion in the urine. This is important because calcium and phosphate can precipitate together as calcium phosphate crystals if both are elevated simultaneously. By promoting phosphate excretion while raising calcium levels, PTH prevents this precipitation and allows blood calcium to rise safely. In chronic kidney disease, the kidney's ability to excrete phosphate declines, leading to phosphate retention. The kidney also can't activate vitamin D effectively, reducing intestinal calcium absorption. Low calcium and high phosphate together stimulate PTH secretion chronically, a condition called secondary hyperparathyroidism. Over time, this can lead to bone disease, soft tissue calcification, and cardiovascular complications, a complex disorder called chronic kidney disease mineral and bone disorder, or CKD-MBD. Management involves dietary phosphate restriction, phosphate binders that prevent intestinal phosphate absorption, supplementation with active vitamin D or its analogs, and sometimes medications called calcimimetics that make the parathyroid glands more sensitive to calcium, reducing PTH secretion even when calcium levels are suboptimal. The kidney's production of erythropoietin, which we mentioned earlier, represents another endocrine function that extends the kidney's influence throughout the body. Erythropoietin is produced primarily by fibroblasts in the kidney cortex in response to hypoxia, low oxygen levels. These cells contain oxygen-sensing mechanisms involving proteins called hypoxia-inducible factors, or HIFs. Under normal oxygen conditions, HIFs are continuously produced but immediately degraded by enzymes that require oxygen for their function. When oxygen levels fall, these degrading enzymes can't function, HIFs accumulate, and they activate genes including the erythropoietin gene. The resulting increase in erythropoietin secretion stimulates the bone marrow to produce more red blood cells, increasing oxygen carrying capacity. This feedback system maintains red blood cell numbers and hemoglobin levels within appropriate ranges. It responds to anemia from any cause, to high altitude where atmospheric oxygen is reduced, to lung disease where oxygen uptake is impaired, or to cardiovascular disease where oxygen delivery is compromised. In chronic kidney disease, damaged kidneys produce less erythropoietin and anemia develops. This anemia can be profound and debilitating, causing fatigue, weakness, and shortness of breath. Treatment with synthetic erythropoietin or longer-acting erythropoiesis-stimulating agents can correct the anemia, significantly improving patients' quality of life and potentially reducing cardiovascular complications. Interestingly, some cancers, particularly kidney cancers and liver cancers, can produce erythropoietin autonomously, leading to erythrocytosis, an abnormal increase in red blood cells. This can cause blood to become too viscous, increasing the risk of clots and strokes, demonstrating that more is not always better when it comes to red blood cell production. As we consider these various regulatory systems, the renin-angiotensin-aldosterone system, the ADH system, parathyroid hormone and vitamin D, erythropoietin production, notice how the kidney functions as both a responder and an initiator. It responds to hormonal signals from the brain, the heart, the parathyroid glands, adjusting its function accordingly. But it also initiates hormonal cascades, releasing renin, producing erythropoietin, activating vitamin D, exerting influence over blood pressure, red blood cell production, and bone metabolism. This dual role positions the kidney as a central coordinator of multiple physiological systems. It is both servant and master, responding to commands while issuing commands of its own, creating intricate feedback loops that maintain stability across seemingly disparate functions. Let us now examine how kidney function is assessed clinically, for understanding these tests illuminates what we consider normal kidney function and how we detect dysfunction. The most basic assessment is urinalysis, examination of the urine itself. A routine urinalysis includes visual inspection, chemical analysis using a test strip, and microscopic examination of the sediment. Urine color normally ranges from pale yellow to amber, depending on concentration. Dark urine might indicate dehydration, while very pale urine suggests dilution. Red or brown urine could indicate blood, while other colors might result from foods, medications, or metabolic disorders. Clarity should be clear or slightly hazy. Cloudy urine might indicate infection, crystals, or other abnormalities. The chemical test strip assesses multiple parameters simultaneously. pH normally ranges from 4.5 to 8, but is typically around 6, slightly acidic. Very acidic urine might occur with high-protein diets or metabolic acidosis, while alkaline urine might indicate urinary tract infections with certain bacteria that produce ureas, an enzyme that breaks down urea into ammonia. Protein should be absent or present only in trace amounts in normal urine. Most proteins are too large to pass through the glomerular filtration barrier, and the small amount that does filter through is almost completely reabsorbed in the proximal tubule. Significant proteinuria, protein in the urine, indicates either glomerular damage that allows proteins to filter inappropriately or tubular damage that prevents normal reabsorption. Persistent proteinuria is often the first sign of chronic kidney disease. Glucose should be absent. Its presence indicates either that blood glucose exceeded the renal threshold, as in diabetes mellitus, or that proximal tubule reabsorption is impaired. Ketones, produced when the body breaks down fat for energy, appear in urine during starvation. Very low carbohydrate diets or diabetic ketoacidosis, a dangerous complication of diabetes. Blood in urine, hematuria, can be microscopic, visible only under the microscope, or gross, visible to the naked eye. It might originate from anywhere in the urinary tract, the kidneys, ureters, bladder, or urethra. Causes range from kidney stones to infections, from glomerular disease to tumors, requiring further investigation to determine the source and cause. Leukocyte esterase and nitrites on the test strip suggest urinary tract infection. White blood cells in urine produce leukocyte esterase, while many bacteria convert urinary nitrate to nitrite. Together, these findings indicate probable infection, though culture is needed to identify the specific organism and guide antibiotic therapy. Microscopic examination of urine sediment, the material that settles when urine is centrifuged, can reveal cells, crystals, casts, and microorganisms. Red blood cells and white blood cells can be counted. Various crystal types might appear, some normal and some associated with stone formation or metabolic disorders. Casts are cylindrical structures formed in the tubules, made of protein and potentially including trapped cells. Their presence often indicates kidney disease rather than lower urinary tract problems. Beyond urinalysis, blood tests assess kidney function. Serum creatinine, as we've discussed, reflects GFR. Normal values range from approximately 0.7 to 1.3 milligrams per deciliter in adult men and 0.6 to 1.1 in adult women, though values vary with muscle mass, age, and other factors. Elevated creatinine suggests reduced GFR and impaired kidney function. Blood urea nitrogen, or BUN, measures urea in the blood. Normal values range from 7 to 20 milligrams per deciliter. Elevated BUN can indicate kidney dysfunction, but also increases with dehydration, high protein intake, bleeding in the digestive tract, or increased protein breakdown. The BUN to creatinine ratio can help distinguish between these causes. Estimated GFR, calculated from creatinine along with age, sex, and sometimes race, provides a more accurate assessment of kidney function than creatinine alone. Values above 90 milliliters per minute per 1.73 square meters of body surface area are considered normal. Values between 60 and 89 are mildly reduced. 30 to 59 indicate moderate reduction, 15 to 29 indicate severe reduction, and below 15 indicates kidney failure. Electrolyte panels measure sodium, potassium, chloride, and bicarbonate. Abnormalities can indicate various kidney disorders or systemic conditions affecting kidney function. Calcium, phosphate, and magnesium levels provide additional information, particularly important in chronic kidney disease where mineral metabolism is disturbed. Imaging studies visualize the kidneys structurally. Ultrasound is often the first test, providing information about kidney size, shape, and the presence of masses, cysts, stones, or obstruction without radiation exposure. CT scans offer more detailed images and can detect smaller abnormalities but involve radiation. MRI provides excellent soft tissue detail without radiation, useful for characterizing masses or assessing blood vessel anatomy. Kidney biopsy, obtaining a small tissue sample for microscopic examination, is sometimes necessary to diagnose specific kidney diseases, particularly glomerular diseases where the disease process affects the filtration barrier itself. A needle is inserted through the skin into the kidney under imaging guidance, and a core of tissue is removed. Pathologists examine this tissue under light microscopy, immunofluorescence microscopy to detect antibody or complement deposits, and electron microscopy to see ultrastructural details, providing precise diagnosis that guides treatment. These diagnostic tools allow physicians to assess kidney function comprehensively, detecting problems early when intervention can prevent progression, differentiating between different types of kidney disease, and monitoring response to treatment. The kidney's complexity requires this multifaceted assessment, no single test captures the full picture. As we've moved deeper into the kidney's mechanisms and clinical assessment, notice how each system connects to others. The RAAS connects kidney function to blood pressure and cardiovascular health. Erythropoietin production connects kidneys to oxygen transport and bone marrow function. Vitamin D activation connects kidneys to bone health and calcium metabolism. Acid-base regulation connects kidneys to respiratory function and cellular metabolism. The kidney emerges not as an isolated organ, but as a nexus, a point where multiple systems converge and interact. Understanding the kidney requires understanding its place in the body's larger organization, appreciating how it both shapes and is shaped by the organism as a whole. Even now, as you continue reading, your kidneys are participating in dozens of regulatory loops simultaneously, adjusting and responding, maintaining you in balance through constant, intricate work that requires no conscious attention. Only the quiet wisdom built into these remarkable organs through millions of years of evolutionary refinement. We return once more to the kidneys, and now we venture into the territories where structure meets dysfunction, where understanding healthy physiology illuminates the nature of disease. We have journeyed through the foundational architecture of the renal system and explored the intricate regulatory mechanisms that allow these organs to maintain chemical balance, control blood pressure, and coordinate with distant systems throughout the body. Now, we turn our attention to the patterns of kidney disease, the clinical conditions that disrupt this harmony, and the ways the body responds when these vital organs falter. As you settle into this next phase of our exploration, notice that your own kidneys continue their steady work, undisturbed by our discussion of pathology. They filter and adjust, reabsorb and secrete, responding to signals you'll never consciously perceive. This ongoing function, even as we examine what happens when function fails, reminds us that knowledge of disease serves ultimately to deepen our appreciation of health. Let us begin with glomerular diseases, conditions that primarily affect the filtration barrier itself. The glomerulus, you'll recall, is that intricate tuft of capillaries where blood filtration begins, surrounded by Bowman's capsule. The glomerular filtration barrier consists of 3 layers: the fenestrated endothelium of the capillaries with its small pores, the glomerular basement membrane, a thick layer of specialized extracellular matrix, and the podocytes, remarkable cells with foot-like processes that wrap around the capillaries, creating filtration slits between adjacent processes. This barrier allows water and small solutes to pass while retaining blood cells and most proteins. When this barrier is damaged, proteins leak into the filtrate and appear in the urine, a condition called proteinuria. The pattern and severity of proteinuria often indicates the type and extent of glomerular damage. Nephrotic syndrome represents a constellation of findings that occur when glomerular damage is severe enough to allow substantial protein loss. Patients develop heavy proteinuria, typically exceeding 3.5 grams per day. This protein loss, particularly of albumin, the most abundant plasma protein, leads to hypoalbuminemia, low blood albumin levels. Albumin normally exerts osmotic pressure that helps keep fluid in the bloodstream. When albumin levels fall, fluid leaks from blood vessels into tissues, causing edema, swelling that often appears first around the eyes and in the legs. The liver responds to low albumin by increasing production not only of albumin, but also of lipoproteins, leading to hyperlipidemia, elevated blood cholesterol, and triglycerides. The urine may appear foamy due to the high protein content. Patients are also at increased risk of infections because immunoglobulins, the antibody proteins, are lost in urine, and at increased risk of blood clots because anticoagulant proteins are lost while the liver increases production of clotting factors. Several diseases can cause nephrotic syndrome. Minimal change disease, most common in children but also occurring in adults, shows almost no abnormalities on light microscopy, but reveals fusion of podocyte foot processes on electron microscopy. The cause is often unclear, though it may follow infections or vaccinations, suggesting an immune trigger. The disease typically responds well to corticosteroid treatment, with protein loss resolving and kidney function remaining preserved. Focal segmental glomerulosclerosis, or FSGS, shows scarring in some glomeruli, some segments, leaving others unaffected. It can be primary, arising without clear cause, or secondary to conditions like obesity, HIV infection, or sickle cell disease. FSGS often progresses to kidney failure despite treatment, though some patients respond to immunosuppressive medications. Membranous nephropathy involves thickening of the glomerular basement membrane with deposits of immune complexes. It's often idiopathic, meaning no cause is identified, though it can occur with autoimmune diseases, infections, or certain cancers. About 1/3 of cases resolve spontaneously, 1/3 remain stable, and 1/3 progress to kidney failure. Treatment depends on the severity and progression rate. Diabetic nephropathy, kidney damage from diabetes mellitus, is the most common cause of nephrotic syndrome and chronic kidney disease in developed countries. High blood glucose over years damages the glomerular capillaries, causing the basement membrane to thicken and the mesangium, supporting tissue within the glomerulus, to expand. Eventually, glomeruli become scarred and non-functional. Early diabetic nephropathy presents with microalbuminuria, small amounts of albumin in urine detectable only by sensitive tests. This can progress to overt proteinuria and declining kidney function. Controlling blood glucose and blood pressure can slow the progression of diabetic nephropathy. ACE inhibitors and angiotensin receptor blockers are particularly beneficial because they reduce intraglomerular pressure by dilating the efferent arteriole, protecting the glomerulus from damage caused by excessive filtration pressure. Still, many diabetic patients eventually require dialysis or transplantation, making diabetes prevention and early management crucial for reducing the burden of kidney disease. Nephritic syndrome, distinct from nephrotic syndrome, presents with hematuria, red blood cells in urine, often with red blood cell casts that indicate the blood originated in the glomeruli. Patients develop hypertension, edema, and reduced GFR, but protein loss is usually less severe than in nephrotic syndrome. The urine may appear cola-colored or tea-colored from the presence of blood. Post-infectious glomerulonephritis, classically occurring 1 to 3 weeks after a streptococcal throat or skin infection, results from immune complexes depositing in glomeruli, triggering inflammation. Children are most commonly affected. The immune system's response to the infection produces antibodies that form complexes with bacterial antigens, and these complexes lodge in the glomerular capillaries, activating complement and recruiting inflammatory cells. The resulting inflammation damages the filtration barrier, allowing red blood cells and protein to leak into the urine. Most cases resolve spontaneously as the immune response subsides, though supportive care for hypertension and edema may be necessary during the acute phase. Kidney function typically recovers fully in children, though adults may have residual damage. Rapidly progressive glomerulonephritis is a medical emergency where kidney function deteriorates over days to weeks. Patients develop severe inflammation in glomeruli with crescent formation, accumulations of cells in Bowman space that compress the glomerular tuft. Without prompt treatment with immunosuppressive medications and sometimes plasmapheresis, the removal of antibodies from blood, irreversible kidney failure ensues. Several diseases can cause rapidly progressive glomerulonephritis, including antiglomerular basement membrane disease, where antibodies attack the basement membrane in both kidneys and often the lungs, causing a syndrome called good pasture syndrome. ANCA-associated vasculitis, where antibodies against neutrophil proteins cause inflammation in small blood vessels, including glomeruli, and immune complex diseases like lupus nephritis. Lupus nephritis occurs in systemic lupus erythematosus, an autoimmune disease where the immune system attacks multiple organs. Immune complexes deposit in glomeruli, causing inflammation that varies in severity from mild proteinuria to rapidly progressive glomerulonephritis. Treatment involves immunosuppressive medications to control the autoimmune process, and prognosis depends on the severity of kidney involvement and response to treatment. These glomerular diseases illustrate how immune dysfunction, metabolic disturbances, infections, and genetic factors can disrupt the delicate filtration barrier. The kidney, exposed to the body's entire blood volume repeatedly each day, becomes vulnerable to any circulating antibodies, immune complexes, toxins, or abnormal substances that might damage its intricate structures. Beyond glomerular diseases, tubular and interstitial diseases affect the nephron tubules and the surrounding tissue. Acute tubular necrosis, or ATN, is the most common cause of acute kidney injury in hospitalized patients. It occurs when tubular cells are damaged by ischemia, inadequate blood flow, or by toxins. Ischemic ATN results from prolonged hypotension, severe bleeding, septic shock, or cardiac arrest, situations where kidney blood flow is severely reduced. The tubular cells, particularly in the proximal tubule and thick ascending limb where energy demands are high, suffer injury when deprived of oxygen and nutrients. Cells may die, slough off into the tubule lumen, and obstruct urine flow. The kidney's ability to concentrate urine and regulate electrolytes is impaired. Toxic ATN results from exposure to nephrotoxic substances. Certain antibiotics, particularly aminoglycosides and amphotericin B, can damage tubular cells. Contrast dye used in CT scans and angiograms can cause kidney injury, especially in patients with pre-existing kidney disease, diabetes, or dehydration. Pigments like myoglobin, released from damaged muscle in rhabdomyolysis, or hemoglobin, released from lysed red blood cells, can precipitate in tubules and cause injury. Heavy metals, organic solvents, and certain chemotherapy drugs are also nephrotoxic. ATN typically presents with a sudden rise in creatinine and reduced urine output, though some patients maintain urine output while losing concentrating ability. The urine sediment shows muddy brown casts, clumps of dead tubular cells. Treatment is primarily supportive, maintaining adequate hydration and blood pressure, avoiding further nephrotoxic exposures, adjusting medication doses for reduced kidney function, and sometimes providing dialysis temporarily until the tubular cells regenerate. The kidney has remarkable regenerative capacity. Tubular cells can proliferate and restore tubular integrity over days to weeks, and kidney function often recovers completely from ATN if the underlying cause is addressed and the injury wasn't too severe or prolonged. However, severe or repeated ATN episodes can lead to chronic scarring and permanent kidney damage. Interstitial nephritis involves inflammation of the kidney interstitium, the tissue between tubules. Acute interstitial nephritis often results from allergic reactions to medications, particularly antibiotics like penicillins and cephalosporins, NSAIDs like ibuprofen and naproxen, and proton pump inhibitors used for acid reflux. The immune system mounts a hypersensitivity reaction against the drug, and inflammatory cells infiltrate the kidney interstitium, disrupting tubular function. Patients may develop fever, rash, and eosinophilia, elevated eosinophils in the blood, along with acute kidney injury. Urine examination shows white blood cells, sometimes including eosinophils, a clue to the diagnosis. Discontinuing the offending medication usually leads to recovery, though corticosteroids may be used in severe cases to reduce inflammation. Chronic interstitial nephritis develops over months to years and can result from prolonged medication use, chronic urinary obstruction, recurrent infections, or exposure to heavy metals like lead or cadmium. The interstitium becomes fibrotic, scarred, and tubules are lost. Unlike acute interstitial nephritis, the damage is often irreversible, leading to progressive chronic kidney disease. Polycystic kidney disease represents a group of genetic disorders where fluid-filled cysts develop in the kidneys, progressively enlarging and replacing normal kidney tissue. Autosomal dominant polycystic kidney disease, or ADPKD, is one of the most common genetic diseases, affecting approximately 1 in 500 to 1,000 people. Mutations in genes encoding polycystin proteins, which are involved in cell signaling and structure, lead to cyst formation. Cysts arise from tubular segments and grow over time, filled with fluid that has a composition similar to filtrate. As cysts enlarge, they compress surrounding nephrons, reduce blood flow, and cause scarring. The kidneys can become massively enlarged, each potentially weighing several kilograms compared to the normal 150 grams, filled with countless cysts of varying sizes. Patients often remain asymptomatic until adulthood. The first manifestations might be high blood pressure, back or flank pain from enlarged kidneys, blood in urine from cyst rupture or urinary tract infections. Kidney function declines gradually, with about half of patients developing kidney failure by age 60. ADPKD also causes cysts in other organs, particularly the liver, though liver cysts rarely impair liver function. Patients are at increased risk of cerebral aneurysms, weakened areas in brain blood vessels that can rupture and cause hemorrhagic stroke. Screening with brain imaging is recommended for patients with a family history of aneurysms or hemorrhage. Treatment focuses on controlling blood pressure, managing pain, treating infections and stones, and slowing cyst growth. A medication called tolvaptan, a vasopressin receptor antagonist, can slow cyst growth and kidney function decline in selected patients, though it requires monitoring for liver toxicity. Ultimately, many patients require dialysis or transplantation. Autosomal recessive polycystic kidney disease is rarer and more severe, presenting in infancy or childhood with enlarged kidneys and kidney failure. It also causes liver fibrosis and portal hypertension. Management is challenging, and many affected children require transplantation. Kidney stones, or nephrolithiasis, affect approximately 10% of people at some point in their lives, causing significant pain and potentially obstructing urine flow. Stones form when substances in the urine become supersaturated and crystallize, then aggregate into larger masses. The most common stones are calcium-based, either calcium oxalate or calcium phosphate. Risk factors include low urine volume from inadequate fluid intake, high urinary calcium from excessive dietary intake or from bone resorption, high urinary oxalate from dietary sources like spinach and nuts, or from increased intestinal absorption in certain bowel diseases, and alkaline urine pH that promotes calcium phosphate precipitation. Uric acid stones form when urine is acidic and contains high levels of uric acid, often in patients with gout, high purine diets, or conditions causing rapid cell turnover like chemotherapy for cancer. Struvite stones, composed of magnesium ammonium phosphate, form in the presence of urease-producing bacteria, typically during urinary tract infections. These can grow rapidly into large staghorn calculi that fill the renal pelvis and calyces. Cystine stones occur in cystinuria, a genetic disorder causing defective reabsorption of cysteine and other amino acids in the proximal tubule, leading to high urinary cysteine levels and stone formation. Stones may remain asymptomatic in the kidney or may cause pain when they obstruct the ureter. Renal colic, the pain from a ureteral stone, is often described as among the most severe pains humans experience, a sharp, cramping pain that radiates from the flank to the groin, often accompanied by nausea and vomiting. Patients may see blood in their urine from the stone abrading the urinary tract lining. Small stones, typically less than 5 millimeters, often pass spontaneously with hydration and pain management. Larger stones may require intervention. Shockwave lithotripsy, using focused ultrasound waves to fragment the stone from outside the body. Ureteroscopy, threading a scope through the urethra and bladder into the ureter to remove or fragment the stone. Or percutaneous nephrolithotomy, creating a small skin incision to access the kidney directly for large stone removal. Prevention involves identifying the stone composition through analysis of past or removed stones and addressing underlying causes. Increasing fluid intake to produce at least 2 liters of urine daily is universally beneficial. Dietary modifications might include reducing sodium intake, moderating protein consumption, and limiting oxalate-rich foods for calcium oxalate stones, or reducing purine intake for uric acid stones. Medications can reduce urinary calcium excretion, alkalinize urine for uric acid stones, or acidify urine for struvite stone prevention. Urinary tract infections, or UTIs, are among the most common bacterial infections, particularly affecting women due to their shorter urethras. Most UTIs are bladder infections, cystitis, causing urinary frequency, urgency, burning with urination, and sometimes blood in the urine. They're typically caused by Escherichia coli bacteria from the intestinal tract that ascend through the urethra. When infection ascends to the kidneys, it causes pyelonephritis, manifesting with fever, chills, flank pain, nausea, and vomiting in addition to urinary symptoms. The kidney becomes inflamed, and bacteria may enter the bloodstream, causing bacteremia or sepsis in severe cases. Pyelonephritis requires prompt antibiotic treatment to prevent kidney damage and complications. Recurrent UTIs can lead to chronic pyelonephritis, causing scarring and progressive kidney damage over time. This is more common when there's underlying structural abnormality, urinary obstruction, or vesicoureteral reflux, where urine flows backward from the bladder into the ureters and potentially into the kidneys. Hypertensive kidney disease, or nephrosclerosis, results from prolonged high blood pressure damaging the kidney's blood vessels. The arterioles develop thickening of their walls, a process called arteriolosclerosis, reducing blood flow to nephrons. Glomeruli become scarred, a condition called glomerulosclerosis, and tubules atrophy. Over years, this leads to progressive kidney function decline. The relationship between hypertension and kidney disease is complex and bidirectional. Hypertension damages kidneys, but kidney disease also causes or worsens hypertension through mechanisms, including activation of the renin-angiotensin-aldosterone system, sodium and water retention, and endothelial dysfunction. This creates a cycle where hypertension and kidney disease reinforce each other. Malignant hypertension, a hypertensive emergency with very high blood pressure, typically above 180-120 millimeters of mercury, with signs of acute organ damage, can cause acute kidney injury. The kidneys show acute arteriolar necrosis, death of arteriolar walls, with red blood cells fragmenting as they squeeze through damaged vessels. Immediate blood pressure reduction is necessary to prevent permanent kidney damage. Controlling blood pressure is crucial for kidney protection. ACE inhibitors and angiotensin receptor blockers are particularly renoprotective, slowing the progression of both diabetic and non-diabetic kidney disease beyond their blood pressure lowering effects alone. Acute kidney injury, which we've touched upon in discussing ATN and other conditions, deserves synthesis as a clinical syndrome. AKI is defined as a sudden decline in kidney function, evidenced by rising creatinine, reduced urine output, or both. It's classified into three categories based on cause: pre-renal, resulting from inadequate blood flow to the kidneys; intrinsic or intrarenal, resulting from damage within the kidneys themselves; and postrenal, resulting from urinary tract obstruction. Pre-renal AKI occurs when kidney perfusion is reduced, but the kidney tissue itself is initially undamaged. Causes include dehydration, bleeding, heart failure reducing cardiac output, liver failure causing abnormal blood flow distribution, or medications like NSAIDs that impair the kidney's autoregulatory mechanisms. The kidneys respond by activating the RAAS, retaining sodium and water, and producing concentrated urine with low sodium content. If perfusion is restored promptly, kidney function recovers without lasting damage. However, prolonged prerenal AKI can progress to intrinsic AKI as tubular cells suffer ischemic injury. Intrinsic AKI involves damage to kidney structures. We've discussed several causes: ATN from ischemia or toxins, glomerulonephritis, interstitial nephritis. The urine sediment typically shows abnormalities like cells, casts, or protein, clues to the underlying pathology. Treatment depends on the specific cause, but often involves addressing the underlying disorder, avoiding further kidney injury, and providing supportive care. Postrenal AKI results from obstruction preventing urine drainage. Obstruction can occur at the bladder outlet, as with an enlarged prostate, urethral strictures, or neurogenic bladder, or at the ureters, as with kidney stones, tumors, or retroperitoneal fibrosis. Bilateral ureteral obstruction or obstruction in a patient with only one functional kidney is necessary to cause AKI, since a single kidney can maintain adequate function. Obstruction causes pressure to build in the urinary collecting system, transmitted back to the nephrons, opposing filtration. GFR falls, and if obstruction persists, kidney damage ensues. Relieving the obstruction, often with catheter drainage or ureteral stent placement, allows recovery if performed before permanent damage occurs. Chronic kidney disease, progressive kidney function loss over more than 3 months, affects approximately 15% of adults. We've mentioned several causes: diabetes, hypertension, glomerular diseases, polycystic kidney disease, chronic interstitial nephritis. Regardless of the initial cause, CKD tends to progress through similar mechanisms. When nephrons are lost, remaining nephrons undergo adaptive hyperfiltration, increasing their individual GFR to compensate. This adaptation maintains near normal total GFR initially, but places stress on the remaining nephrons. The increased glomerular pressure and flow contribute to further glomerular damage, proteinuria, and scarring. The process becomes self-perpetuating. Nephron loss leads to hyperfiltration in remaining nephrons, which leads to more nephron damage and loss. Additionally, the diseased kidney produces inflammatory mediators and profibrotic factors that promote scarring throughout the kidney tissue. The interstitium becomes fibrotic, tubules atrophy, and glomeruli scar. This scarring is largely irreversible, representing the final common pathway of many different kidney diseases. CKD is staged based on GFR. Stage 1 shows kidney damage with normal or elevated GFR above 90. Stage 2 shows mild reduction, GFR 60 to 89. Stage 3 is split into 3A, GFR 45 to 59, and 3B, GFR 30 to 44, both indicating moderate reduction. Stage 4 shows severe reduction, GFR 15 to 29. Stage 5 is kidney failure, GFR below 15, where dialysis or transplantation is typically necessary. Patients with early CKD may be asymptomatic, the condition detected only through routine blood or urine tests. As kidney function declines, symptoms develop. Fatigue and weakness appear from anemia and toxin accumulation. Edema develops from fluid retention. Nausea and decreased appetite result from uremia, the accumulation of waste products. Itching occurs from mineral imbalances and toxin deposition in skin. Altered mental status can occur in advanced uremia. Complications of CKD include cardiovascular disease, the leading cause of death in CKD patients, with increased risk of heart attacks, heart failure, arrhythmias, and sudden cardiac death. The mechanisms are multiple: hypertension, fluid overload, anemia, mineral and bone disorder with vascular calcification, chronic inflammation, and oxidation stress all contribute. The mineral and bone disorder in CKD involves phosphate retention, vitamin D deficiency, hypocalcemia, and secondary hyperparathyroidism. Elevated phosphate and PTH, along with vitamin D deficiency, contribute to bone disease, either high bone turnover from excess PTH or low bone turnover from oversuppression of PTH. Calcium and phosphate can deposit in blood vessels and soft tissues, accelerating cardiovascular disease and causing calciphylaxis, a rare but devastating condition where small blood vessels calcify, causing skin necrosis and intense pain. Anemia in CKD results from decreased erythropoietin production, shortened red blood cell lifespan from uremic toxins, and sometimes iron deficiency. Treatment with erythropoiesis-stimulating agents and iron supplementation can improve energy and quality of life. Metabolic acidosis develops as the kidneys lose their ability to excrete the daily acid load from metabolism. Treatment with sodium bicarbonate supplements can correct acidosis, potentially slowing CKD progression. Management of CKD focuses on slowing progression and preventing complications. Controlling blood pressure, particularly with ACE inhibitors or angiotensin receptor blockers, is paramount. Managing diabetes tightly reduces diabetic nephropathy progression. Dietary modifications include protein restriction to reduce uremic toxin production and the workload on remaining nephrons. Phosphate restriction to prevent mineral bone disorder, potassium restriction if hyperkalemia develops, and sodium restriction to control blood pressure and edema. Avoiding nephrotoxic medications. particularly NSAIDs and certain antibiotics, prevents additional kidney damage. Regular monitoring allows early detection and management of complications. Patient education empowers people to participate actively in their care. When CKD progresses to stage 5, renal replacement therapy becomes necessary. We've mentioned hemodialysis and peritoneal dialysis. Each has advantages and disadvantages. Hemodialysis provides efficient clearance but requires vascular access, typically an arteriovenous fistula surgically created by connecting an artery to a vein, usually in the forearm, creating a high-flow vessel suitable for repeated needle access. Treatment occurs 3 times weekly, each session lasting 3 to 5 hours, requiring patients to travel to dialysis centers. Peritoneal dialysis can be performed at home, offering more independence and flexibility. However, it requires a permanent catheter in the abdomen and carries risks of peritonitis, infection of the peritoneal cavity. Some patients eventually develop peritoneal membrane failure, where the membrane becomes less effective for dialysis. Kidney transplantation offers the best outcomes, improving survival and quality of life compared to chronic dialysis. Living donor transplants from healthy individuals donating 1 kidney provide the best results with immediate function and longer graft survival. Deceased donor transplants depend on organ availability, requiring patients to wait on transplant lists. Transplant recipients require lifelong immunosuppressive medications to prevent rejection. These medications suppress the immune system's ability to recognize the transplanted kidney as foreign, but also increase infection risk and can cause side effects, including diabetes, hypertension, and increased cancer risk. Despite these challenges, most transplant recipients consider the trade-off worthwhile for freedom from dialysis and improved quality of life. Rejection can occur as hyperacute rejection within minutes to hours caused by pre-existing antibodies against the donor kidney, acute rejection within weeks to months from T-cell mediated attack on the transplant, or chronic rejection over months to years, a process involving both immune and non-immune mechanisms leading to gradual graft function decline. As we move through these patterns of kidney disease, notice the themes that emerge. The kidney's exposure to the entire blood volume makes it vulnerable to systemic diseases, toxins, and immune complexes circulating in the blood. Its high metabolic activity makes it susceptible to ischemia when blood flow is compromised. Its delicate filtration barrier can be disrupted by immune dysfunction, metabolic disturbances, or genetic abnormalities. Its regulatory functions mean that kidney disease affects not just waste excretion, but blood pressure, bone health, red blood cell production, and acid-base balance. Yet the kidney also demonstrates resilience. Acute injuries often resolve with supportive care. The organ's regenerative capacity allows tubular cell replacement and functional recovery. Even with substantial nephron loss, remaining nephrons can compensate remarkably, maintaining near normal function until late in disease progression. This reserve capacity provides opportunities for intervention, for slowing disease progression through blood pressure control, metabolic management, and avoidance of further injury. The study of kidney disease reveals both vulnerability and resilience, both the fragility of complex biological systems and their remarkable adaptive capacity. It shows us that maintaining health requires attention to multiple factors: blood pressure, blood sugar, hydration, medication safety, infection prevention. It demonstrates how one organ's dysfunction ripples through multiple body systems, affecting heart, bones, blood, and more. We arrive now at the completion of our journey through the renal system, carrying with us the understanding we've gathered, the architecture of these paired organs, the elegant mechanisms that maintain chemical balance, the regulatory networks that position the kidney at the center of multiple physiological systems, and the patterns of disease that emerge when this intricate machinery falters. In this final exploration, we turn our attention to integration, to the kidney's place in the whole organism, to recent advances that are reshaping our understanding and treatment of kidney disease, and finally, to a gentle gathering of all we've discovered, the room around you, the surface that supports you, the rhythm of your breathing, all remain constant as we continue. Your kidneys, too, remain constant in their work, filtering and adjusting, responding to signals, maintaining equilibrium. This final section asks you simply to allow the information to settle, to find its place among what you already know without effort or strain. Let us consider the kidney in evolutionary perspective, for this organ's design reflects millions of years of refinement across countless species adapting to diverse environments. The fundamental challenge of managing water and waste is universal among animals, yet solutions vary dramatically depending on whether an organism lives in freshwater, saltwater, or on land. Freshwater fish face the problem of living in an environment more dilute than their body fluids. Water constantly enters through their gills and skin by osmosis, threatening to dilute their internal chemistry. Their kidneys produce large volumes of very dilute urine, eliminating the excess water while conserving salts. Special cells in the gills actively absorb salts from the surrounding water to replace those lost in urine. Marine fish face the opposite challenge. The ocean is saltier than their tissues, so they lose water by osmosis and gain salt. They drink seawater and produce small volumes of concentrated urine. Special salt-secreting cells in their gills actively pump excess salt out into the ocean, preventing salt accumulation. Desert mammals have evolved extraordinarily efficient kidneys capable of producing highly concentrated urine to conserve water. The kangaroo rat, living in arid regions with minimal water intake, has exceptionally long loops of Henle that create very steep medullary osmotic gradients, allowing urine concentration far exceeding what human kidneys can achieve. These animals can survive without drinking water, obtaining all necessary moisture from the metabolic breakdown of food. Marine mammals like whales and dolphins have kidneys with multiple lobes called raniculi, each essentially a miniature kidney. This design may help manage the large blood volumes these animals process or provide redundancy in the harsh marine environment. Their kidneys can concentrate urine beyond human capacity, managing the high protein diet from fish while minimizing water loss. The human kidney represents an adaptation for terrestrial life with access to water, but requiring conservation during periods of scarcity. Our ability to vary urine concentration from about 50 to 1200 millismoles per kilogram gives us flexibility to match fluid excretion to intake and losses. This adaptability has allowed humans to inhabit diverse environments from humid tropics to arid deserts. The basic nephron structure appears across vertebrate species with variations reflecting environmental demands. The glomerulus, the tubular segments, the loop structure, the collecting system, these elements are conserved, suggesting their fundamental importance. Evolution has optimized this design over hundreds of millions of years, producing the sophisticated filtering apparatus we carry within us. This evolutionary perspective reminds us that the kidney is not arbitrary in its design, but shaped by the physical and chemical laws governing life. The need to eliminate waste while conserving water and valuable nutrients has driven the evolution of increasingly complex filtration and reabsorption systems, culminating in the mammalian kidney's remarkable capabilities. Recent research continues to unveil new dimensions of kidney function and new therapeutic approaches for kidney disease. Understanding of the kidney's endocrine functions has expanded beyond the classical hormones. The kidney produces and responds to numerous signaling molecules involved in inflammation, fibrosis, metabolism, and cell communication. Clotho, a protein predominantly expressed in the kidney, has emerged as a factor in aging and mineral metabolism. Clotho functions as a co-receptor for fibroblast growth factor 23, FGF23, a hormone produced by bone in response to phosphate levels. FGF23 inhibits phosphate reabsorption in the proximal tubule and suppresses vitamin D activation, providing additional regulation of phosphate balance beyond PTH. Clotho deficiency, which occurs in chronic kidney disease, may contribute to accelerated aging, vascular calcification, and cognitive decline observed in kidney patients. The discovery of sodium glucose cotransporter 2, or SGLT2 inhibitors, has revolutionized diabetes and kidney disease treatment. These medications, originally developed to lower blood glucose in diabetes by blocking glucose reabsorption in the proximal tubule, causing glucose excretion in urine, were found to have unexpected kidney and cardiovascular benefits. They reduce the risk of kidney disease progression, heart failure, and cardiovascular death, effects that appear to extend beyond glucose lowering. The mechanisms underlying these benefits are still being elucidated, but may involve reduced intraglomerular pressure, decreased kidney oxygen consumption, metabolic effects, and anti-inflammatory properties. SGLT2 inhibitors are now recommended for patients with diabetic kidney disease and are being studied in non-diabetic kidney disease with promising early results. Stem cell research offers potential future therapies for kidney disease. The kidney has limited regenerative capacity for replacing entire nephrons, though tubular cells can regenerate after acute injury. Researchers are exploring whether stem cells could be directed to differentiate into kidney cells, potentially regenerating damaged nephrons, or even growing replacement kidneys in the laboratory. Organoid technology has allowed scientists to grow miniature kidney structures from stem cells, creating simplified kidney tissues that contain multiple cell types organized into rudimentary nephron-like structures. These organoids serve as research tools for studying kidney development, disease modeling, and drug testing. While we're far from growing transplantable kidneys, the progress in understanding how to direct stem cells to form kidney tissues is promising. Gene therapy approaches are being developed for genetic kidney diseases. For conditions like Alport syndrome, caused by mutations in genes encoding collagen proteins in the glomerular basement membrane, introducing functional copies of these genes could potentially slow or prevent disease progression. For polycystic kidney disease, therapies targeting the signaling pathways that drive cyst formation and growth are being investigated. Understanding of kidney-gut interactions has expanded. The gut microbiome, the trillions of bacteria residing in the intestines, influences kidney health through multiple mechanisms. Certain gut bacteria produce uremic toxins, particularly when breaking down protein and amino acids. These toxins are absorbed into the bloodstream and accumulate in kidney disease, contributing to complications. the composition of the gut microbiome changes in kidney disease, a condition called dysbiosis, which may worsen toxin production. Conversely, the kidney influences the gut. Urea and other nitrogenous wastes that accumulate in kidney disease are secreted into the intestines, where they alter the gut environment and microbiome composition. This bidirectional kidney-gut axis is now recognized as important in chronic kidney disease progression and complications. Interventions targeting the microbiome are being studied. Prebiotic fibers that feed beneficial bacteria, probiotic supplements providing beneficial bacteria species, or symbiotics combining both may reduce uremic toxin production. Dietary modifications that limit precursors of uremic toxins while maintaining adequate nutrition are being refined. Artificial kidney technology continues to advance. While dialysis effectively removes small waste molecules and excess fluid, it doesn't replicate all kidney functions. It doesn't produce hormones, doesn't continuously adjust to moment-by-moment changes in body chemistry, and doesn't provide the same clearance of middle-sized molecules as natural kidneys. The bioartificial kidney, being developed by several research groups, aims to combine filtration technology with living kidney cells grown on special membranes. These cells could perform transport, metabolic, and endocrine functions, creating a device that more closely mimics natural kidney function. Wearable artificial kidneys, portable devices that could provide continuous dialysis while allowing patients mobility and normal activities, are also in development. Improved understanding of immune mechanisms in kidney disease has led to more targeted immunosuppressive therapies. Traditional immunosuppression broadly suppresses the immune system, increasing infection risk. Newer approaches aim to selectively block specific pathways involved in kidney injury while preserving general immune function. Monoclonal antibodies targeting complement components, B cells, or specific cytokines are showing promise in glomerular diseases and transplant rejection. Precision medicine approaches seek to tailor treatment to individual patients based on their specific disease characteristics, genetic background, and biomarker profiles. Rather than applying the same treatment to all patients with a particular diagnosis, precision medicine recognizes that diseases like focal segmental glomerulosclerosis or lupus nephritis may have different underlying mechanisms in different patients, requiring different therapeutic approaches. Biomarkers, measurable indicators of biological processes, are being developed to detect kidney injury earlier, predict progression, and monitor treatment response. Novel urinary markers can detect tubular injury before creatinine rises, potentially allowing intervention before irreversible damage occurs. Blood markers may predict which patients are at highest risk of progression, allowing more aggressive treatment for high-risk individuals while avoiding unnecessary treatment in those with stable disease. Remote monitoring technologies allow patients to track blood pressure, weight, and symptoms at home, with data transmitted to care teams who can intervene early if problems develop. This is particularly valuable in heart failure patients, where fluid retention can trigger both cardiac decompensation and kidney injury. Early intervention based on home monitoring can prevent hospitalizations and kidney damage. The recognition of acute kidney injury as not just a temporary problem but a risk factor for future chronic kidney disease has changed clinical practice. Even AKI that resolves completely with creatinine returning to baseline increases the risk of later developing CKD. This may reflect subtle injury to kidney structures that doesn't immediately affect overall function, but creates vulnerability to future insults. This understanding has led to AKI survivor clinics, where patients who experienced AKI are followed long-term, monitored for signs of developing CKD, and counseled on kidney protective strategies. Early identification and management of CKD in these high-risk patients may prevent progression to kidney failure. The social determinants of kidney disease are increasingly recognized. Access to healthcare, socioeconomic status, education, food security, and environmental exposures all influence kidney disease risk and outcomes. Communities with limited access to fresh produce may have diets high in processed foods, with excess sodium and phosphate additives, promoting hypertension and kidney disease. Areas with environmental contamination may expose residents to nephrotoxic heavy metals or chemicals. Addressing kidney disease therefore requires not just medical interventions but also public health approaches, ensuring access to preventive care, improving health literacy, reducing barriers to medication adherence, addressing food deserts, and remediating environmental hazards. This broader perspective recognizes that kidney health is influenced by the contexts in which people live. Patient education and empowerment have emerged as crucial components of kidney disease management. Chronic kidney disease requires daily decisions about diet, medications, fluid intake, and activity. Patients who understand their condition and feel confident in managing it achieve better outcomes than those who passively follow instructions without understanding. Shared decision-making, where patients and clinicians together weigh treatment options considering both medical evidence and patient values and preferences, leads to choices more aligned with what matters to individual patients. For instance, the decision to start dialysis versus pursue conservative management in elderly patients with multiple medical conditions involves trade-offs between lifespan and quality of life that depend on individual priorities. Support groups and peer mentoring programs connect patients with others facing similar challenges, providing emotional support and practical advice. Learning from others who have successfully managed dialysis, undergone transplantation, or navigated dietary restrictions can be invaluable. As we gather these threads together, notice how the kidney appears again and again as an integrator, a coordinator, an organ whose function extends far beyond simple filtration. It regulates blood pressure and thereby protects the heart and brain from hypertensive damage. It maintains acid-base balance and thereby allows cellular metabolism to proceed optimally. It controls mineral metabolism and thereby preserves bone strength. It produces erythropoietin and thereby ensures adequate oxygen delivery to all tissues. When the kidney falters, these interconnections become apparent as multiple systems suffer consequences. The cardiovascular system experiences volume overload and accelerated atherosclerosis. The bones become diseased from mineral imbalance. The blood carries insufficient oxygen. The brain functions suboptimally in uremic conditions. This cascade illustrates how organ systems are not independent units, but components of an integrated whole, each depending on and influencing the others. Yet there is also resilience in this interconnection. The heart can adjust its pumping to maintain kidney perfusion. The liver can increase albumin production to compensate for urinary losses. The bone marrow can increase red cell production when stimulated by erythropoietin. The intestines can excrete more waste when kidneys fail, partly through altered microbiome function. The body mobilizes multiple adaptive mechanisms to maintain function despite kidney disease. This resilience has limits, and when those limits are exceeded, intervention becomes necessary, but the existence of adaptive mechanisms provides windows for therapeutic intervention, opportunities to support the body's own compensatory efforts to slow disease progression to prevent complications. Let us return now to where we began, to the simple fact of kidney function continuing in this moment. Your kidneys are processing blood that circulated through your digestive system, absorbing nutrients from your last meal. They are responding to ADH levels, reflecting your current hydration status. They are reabsorbing glucose that provides energy to cells throughout your body. They are eliminating metabolic waste generated by cellular activity. They are adjusting sodium balance in response to your recent salt intake. They are maintaining pH despite the acids produced by metabolism. All of this occurs without conscious awareness, without deliberate control, guided by mechanisms refined over evolutionary timescales and operating according to the laws of chemistry and physics as applied to biological systems. The kidney represents what biological systems do remarkably well: maintain stability in changing conditions, integrate multiple inputs into coordinated responses, and perform complex tasks reliably over decades. The journey we've taken together through the renal system began with basic anatomy, the structures visible to the eye. We descended into the microscopic realm of nephrons, glomeruli, and tubules. We explored the molecular mechanisms of filtration, transport, and secretion. We examined the regulatory systems that coordinate kidney function with the body's needs. We confronted the diseases that disrupt this machinery and the interventions that support recovery or compensate for lost function. We considered evolutionary origins and future therapeutic directions. Throughout this exploration, certain themes have recurred. The theme of integration, how the kidney participates in multiple physiological systems simultaneously. The theme of regulation, how the kidney both responds to signals and generates signals that influence distant organs. The theme of balance, how the kidney maintains chemical equilibrium despite constant challenges. The theme of vulnerability and resilience, how kidney function can be disrupted, yet also demonstrates remarkable adaptive capacity. These themes extend beyond the kidney to characterize living systems generally. All organs integrate multiple functions. All participate in regulatory networks. All maintain balance within their domains. All show both vulnerability to damage and capacity for adaptation. The kidney simply illustrates these principles with particular clarity. As we come to rest at the conclusion of this extended exploration, allow yourself to notice once more your immediate surroundings, the quality of light, the sounds present or absent, the sensation of your body supported and still. Notice that throughout this entire journey through complex material, your body has continued its fundamental processes. Your heart has beaten steadily. Your lungs have exchanged oxygen and carbon dioxide. Your digestive system has processed nutrients, and your kidneys have filtered blood, adjusted composition, produced urine, maintained you in chemical balance. This automatic, unconscious maintenance of life is perhaps the most remarkable aspect of biological systems. The exquisite complexity we've explored operates reliably without requiring conscious oversight. You need not know about glomerular filtration rates to maintain one. You need not understand the renin-angiotensin-aldosterone system for it to regulate your blood pressure. You need not comprehend countercurrent multiplication for your kidneys to concentrate urine when needed. knowledge of these systems serves purposes beyond operating them. It allows appreciation of the elegance underlying bodily function. It enables recognition when things go wrong and guides interventions to restore health. It connects us to the broader understanding of life, to the evolutionary processes that shaped these organs, to the physical and chemical principles they embody, to the medical science that continues to unveil their mysteries and develop new treatments. The renal system, in all its complexity, in all its integrated function, continues within you. Even now, as you reach the end of this exploration, your kidneys are working. Glomeruli are filtering, tubules are reabsorbing and secreting, collecting ducts are responding to ADH. Juxtaglomerular apparatus cells are monitoring and adjusting. Erythropoietin is being produced. Vitamin D is being activated. All the processes we've discussed are occurring, simultaneously and continuously. You are held in balance by these processes. The stability of your internal environment, the precise chemistry that allows neurons to fire, muscles to contract, enzymes to catalyze reactions, all depends on kidney function. This dependence is profound yet usually invisible, recognized most clearly when kidney function fails and stability deteriorates. There is wisdom in the kidney's operation, the wisdom of systems that have been refined through millions of years, that embody solutions to fundamental challenges facing terrestrial life. The wisdom of maintaining what needs to be constant while flexibly adapting to changing conditions. The wisdom of using feedback loops to self-correct, of having redundancy for reliability, of coordinating multiple functions within elegant structures. This wisdom requires no conscious access. It operates in the depths of the body, in spaces you cannot directly perceive, through mechanisms you do not control. Yet it serves you continuously, faithfully, asking only for adequate blood flow, reasonable protection from toxins, and the basic nutrients needed for cellular metabolism. Rest now in the knowledge that this work continues. The filtration, the reabsorption, the secretion, the regulation, all proceed in their orderly fashion. Your kidneys know their function. They perform it without hesitation, without error under normal conditions, with remarkable consistency across minutes, hours, days, years. You need do nothing to maintain this function except live reasonably, maintain adequate hydration, manage blood pressure and blood glucose if they tend toward excess. Avoid unnecessary exposure to nephrotoxic substances. These simple measures support the kidneys in their work, allowing them to function optimally across a long lifespan. The renal system stands as testament to the sophistication of biological design, to the power of evolutionary refinement, to the remarkable capabilities of living tissue. 2 organs each weighing approximately 150 grams, together comprising less than 0.5% of body weight, process all the blood in your body many times each hour, make millions of molecular decisions each second, maintain dozens of substances within precise ranges, coordinate with multiple organ systems, and adapt continuously to your changing needs. This achievement deserves recognition even as it continues quietly, unremarked, in the background of conscious experience. The kidneys ask for no acknowledgement. They simply work as they have worked since before your birth, as they will continue working through all the days ahead, faithful organs performing their essential service. Let this understanding settle into place alongside all else you know. The renal system, complete in its architecture, elegant in its function, resilient in its adaptations, essential in its contributions. Not separate from the rest of you, but integrated throughout, influencing and influenced by every other system participating in the unified whole that is a living organism. In this completion, in this gathering together of all we've explored, there is a quality of return. We return to the simple awareness with which we began. Kidneys functioning, blood being filtered, balance being maintained. The intervening detail enriches this awareness without replacing it. You know now the mechanisms underlying the function, the structures enabling the processes, the regulatory networks coordinating the responses. Yet the fundamental reality remains unchanged. Your kidneys work reliably and continuously, maintaining you in chemical equilibrium. There is no urgency in this knowledge, no pressure to retain every detail. The information is available should you need it, residing now in memory alongside all else you've learned. What remains most important is the appreciation, the recognition of the elegance operating within you, the acknowledgement of the sophisticated systems that sustain your life without requiring conscious direction. The renal system, in all its completeness, continues its quiet work. This moment and the next moment and all the moments to follow, the filtration proceeds, the adjustments are made, the balance is maintained. You are carried by these processes, supported by this automatic wisdom, held in stability by organs that know their purpose and fulfill it faithfully. Rest in this knowledge. Rest in the certainty of function continuing. Rest in the trust that what has worked reliably until now will continue working reliably ahead. The kidneys require no vigilance from your conscious mind, only the natural conditions of healthy living. They will sustain their work as you rest, as you wake, through all states and situations. Quiet guardians maintaining the chemical conditions upon which all else depends.